Hope you all had a good lunch. We are delighted now to welcome our afternoon keynote speaker, Dr. Kiran Krishnan. So Kiran Krishnan is undisputedly one of the world's experts on the microbiome. He's a research microbiologist who has been involved in the dietary supplement and nutrition market for more than 20 years. He comes from a strict basic science and research background, and he has designed and conducted dozens of human clinical trials on nutrition. He has developed over 50 private label nutritional products in the global market, and he's a frequent lecturer on the microbiome at medical and nutrition conferences. Currently, Kiran is the co-founder and chief scientific officer at Microbiome Labs. He is involved in multiple human clinical trials on probiotics and the human microbiome. Kiran is also on the scientific advisory board for 5 other companies in the industry. He offers his extensive knowledge and practical application of the latest science on the human microbiome as it relates to health and wellness. So please join me in welcoming Dr. Kiran Krishnan.
Hi, Gil. Thank you so much. I really appreciate this opportunity, and thank you everybody for joining us here today. It's a really important message to put forth, because obviously the microbiome is going to become a critical part of any medical practice, any sort of therapeutic, as we venture deeper into the space and understanding the microbiome and its impact on your patient's health. Let me bring up my slides here. Okay, I did it in full mode. And once I start presenting the slides, I'll turn off my camera and then I can put it back on for any Q&A. But the outcome of what you're going to hear today is really work over the last 10 years. And when we set out to really understand the microbiome and understand in particular dysbiosis, our goal was to figure out, number one, how is the microbiome dysbiotic? When it is dysbiotic, what does that actually mean? What does that look like? And then how is that related to chronic illness or disease in any way? So this is really an outcome of studying the microbiome. We've done numerous publications ourselves, and then of course, all of the amazing breadth of knowledge and information that's out there from the over 55,000 research papers that have been produced over the last even 5-6 years. This is really a reconstruction of what it means to be dysbiotic, and then how that affects pathology and how that affects disease. So I term this the most common dysfunctions in the standard American gut, and there should be something that is distinguished as the standard American gut, right? Because we have the standard American diet, we've got lifestyle components within the United States that are pretty common, and all of those things have a huge impact on the microbiome. And what we tend to see, as we've done thousands upon thousands of metagenomics analysis on patient microbiomes, we're seeing some very common trends in how their guts are dysbiotic. And then I can go through today, what I'll do is kind of show you how that dysbiosis in a systematic way breaks down the normal function of the epithelial layer, and breaks down the communication between the immune system and the microbiome, and then also disrupts metabolic processes quite significantly as well. So let's jump into it here. Let me turn off the video, and let's move. So when you look at, when you're trying to understand the microbiome and trying to understand the impact that the microbiome has on a patient's health and outcome, the ground zero for where most things go wrong is obviously in the intestinal lining. It's in the epithelium and the mucosal layer that's sitting above it. And so it becomes really important to kind of hone in on that area and understand what seems to be going wrong when dysbiosis occurs. The first thing that's important to note is a very basic high-level structure of that area. Number one, of course, you've got the intestinal epithelium, which is one cell layer thick. Within those, among those cells are a number of immune cells. There's M cells and L cells and Paneth cells and so on. The intestinal epithelium is a bona fide immune organ, if you will. And of course, it acts as a physical barrier to things entering inside the body, keeping in mind that when things are in the luminal level here, when they're in the lumen, they're actually still considered to be outside the body. Once it gets through the mucosal layers, past the intestinal epithelium and enters into this basolateral circulation, that's when it's officially inside the body, right? Because the intestines obviously are a tube that's open on two ends. So anything entering the intestine, as long as it's still in the luminal layer up here, then it's still considered outside of the body. So governing what is allowed to move through and how it enters into basolateral circulation is a major part of functioning in the world for us. And when that system breaks down, when the governance around how your body is dealing with the things that you're exposed to through diet, through just general exposure in the environment, interaction with other people, things we consume, things we drink, things we expose ourselves to, when the ability to govern those compounds and their ability to enter into the body starts to break down, that's when we start to see the onset of disease pathology. Now, looking here, we've got the intestinal mucosa. The mucosa has two important distinct layers. It's mucin 1 and mucin 2. This inner part of the mucin 2 is deliberately illustrated as being almost sterile. It's not completely sterile, but when you compare it to the outside, the top layer of the mucosa, it is quite a bit more sterile than that, because there's very few organisms that actually live in these the deeper level of the mucin 2 layer, which is directly above the intestinal epithelium. As it turns out, all of these immune cells in the intestinal epithelium really like the idea of having this space in between, where the vast majority of the microbes live in the mucosa up here in the luminal part of the layer, and then keeping them at bay from interacting too much with the intestinal epithelium. This mucin 2 layer kind of acts as that demilitarized zone. And that's the biggest conduit for communication between the microbiome and the immune cells that are on the intestinal epithelium. And then, of course, that message gets translated to all the immune cells that are in the basolateral circulation right underneath as well. And then all of that gets translated, of course, into the systemic immune system, going into the, starting with the influence on the enteric nervous system, then flowing into the vasculature, and of course, the lymphatic system that's all connected to the intestinal epithelium and connected to the digestive tract. So all of this messaging occurs predominantly through this mucin 2 layer. When the mucin 2 layer becomes disrupted, that's when you really start to see disease pathology start. This is the illustration on the right-hand side starts to show you what it looks like when you start getting a disruption of the mucin 2 layer. And disruption of the mucin 2 layer comes from a simple imbalance of microbes that build this system versus microbes that break down the system, right? There is a need to continuously break down the system. There's a need to continuously digest the mucin layer. And then the mucin layer is, of course, then produced by the goblet cells on the intestinal epithelium. And as the goblet cells are producing the mucin layer, it pushes the new mucin layer up, and the old mucin layer sloughs off and, of course, comes out through defecation. So there is this continuous recycling process of the mucin layer, and all of that is controlled in large part by microbes. So there are microbes that do a great job of eating away at this mucin 2 and mucin 1 layer. Of course, it's great bacterial food. These are glycoproteins, there's sugar, there's amino acids. It's warm, there's lots of moisture in this area all the time. And so there are a number of microbes that do a great job digesting the mucin layer, but then there are a number of microbes that are really important in stimulating the rebuilding. Now, most of the most common dysbiosis we see is this imbalance that occurs where you end up having more microbes that break down the mucin layer than microbes that can rebuild it. So what you end up getting is this net picture here, where the mucin 2 layer is compromised and broken down, and then the mucin 1 layer up top here starts to flow into the spaces right next to the intestinal epithelium. Now, this to the immune system in the intestinal epithelium looks like an invasion. It looks like, septicemia that's occurring. And in fact, that's in many ways, when you look at the immune response that occurs when you have this translocation of the microbiome from the top layer down into the inner layer, the immune response is very much like what happens during septicemia. And so the immune system and the intestinal epithelium takes this very seriously, right? So if you start getting a huge number of microbes, even your commensal microbes, moving in right adjacent to the intestinal epithelium and losing that demilitarized zone, that's when you start to see the egregious immune responses. And we'll go through what that looks like from an immune perspective, but just keep in mind that this is what is happening as a fundamental breakdown that is driven by dysbiosis. And remember, the dysbiosis is simply that loss of balance between microbes that eat away and break down the mucin layers and microbes that rebuild it. Now, it can look like this, for example. Let me see if I can advance the slide. So dysbiosis, we can often define it as having low levels of keystone species. So keystone species are organisms within the microbiome that are have been demonstrated to be, number one, typically inversely correlated with loss of disease function. Like, for example, Akkermansia, inversely correlated with everything in the metabolic syndrome spectrum. Faecalibacter prausnitzii, inversely correlated with everything that is involved in IBD, all the conditions that are involved within inflammatory bowel conditions. So those types of keystone species are critically important because one of their primary jobs, they do a lot of things, but one of the primary jobs of keystone species is to maintain the balance within the microbiome between organisms that rebuild and break down the mucosal layer, and then also driving the rebuilding and the reoccurrence or the reconstruction of the mucosal layer, right? So the first thing that we see in the tens of thousands of microbiome analysis that we've done on sick patients, we see very, very low keystone species. And some of the examples I gave you earlier, Akkermansia, Faecalibacteria, Bifidobacterium longum, Bifidobacterium adolescentes, these are really critical organisms that should be present at relatively high amounts when you look at the relative abundance. So for example, Akkermansia can be upwards of 5% of the total microbiome in a healthy individual, right? So one species taking up 5% of the population is really a significant share of the total population. And that's because of how important Akkermansia can be. Faecalibacter prausnitzii can also make up about 5% of the microbiome. So when you think about just these two keystone species themselves, they can make up upwards of 10% of the total microbiome. Most of this is, of course, in the large bowel. You don't really find these organisms in the small bowel. Most of them in the large bowel, and most of the keystone species function and exist in the large bowel. In most sections of the large bowel, we tend to see more Akkermansia and Faecalibacteria as we're moving to the distal end of the large bowel, but we do find them in the proximal end of the large bowel as well. So these keystone species are critically important. And the moment you start reducing the number of keystone species and reducing their numbers, their relative abundance within the microbiome, the next thing that happens is you end up with low diversity in the microbiome. Because one of the things, as I mentioned earlier, that the keystone species do is they provide a capability to sustain diversity within the microbiome, right? They do that by producing postbiotics that influence the growth of certain species to maintain their levels. They can also do some competitive exclusion to inhibit the growth of other species so they can maintain more diversity within the microbiome. So we see it go hand in hand. The moment you start losing keystone species and you start seeing a decline in their relative abundance, you start seeing a decline in diversity overall. And keep in mind, diversity in the microbiome is measured through things like the Shannon Index, where what they're looking at when we look at alpha diversity is really the number of viable species that are found in the microbiome. And one of the scariest things for me as a microbiome researcher and somebody that teaches and lectures on this and studies the impact of the microbiome on human health, one of the scariest things we are seeing, and this has been published by other individuals as well, is we're seeing a significant loss in diversity in the microbiome of North Americans, right? When you compare them, for example, to the Hadza tribe in Tanzania or the Papua New Guinea tribes, the hunter-gatherer tribes that still exist today, that you know have a much more native kind of lifestyle with a high diversity in their diet, lots of resistant starches and roots and tubers and so on, they tend to have almost double the diversity. On average, you see around 300 to 400 species, viable species in their microbiome. Most of the microbiomes we test using shotgun whole genome sequencing, so pretty accurate methodologies for testing the microbiome, we see around 120 species in the average microbiome, which is a really scary thing because when you think about the microbiome is the key to conveying most of the functionality that occurs in our body. When we lose species and functional groups of microbes, we lose capability to function as a human, right? There are some estimates that over 80–90% of all metabolic activity happening in the body occurs in the microbiome before it can trigger any metabolic response in the body, right? At any given time, there was a paper published showing that upwards of 50% of the compounds circulating in your blood come directly from the microbiome, from metabolic processes that are conducted by various microbes in the microbiome, right? So functionality, being human, is dictated in large part by what microbes we have within our microbiome and what genetic elements and what functional capabilities they have. And as we start losing these groups, we literally start losing capability, and we start seeing the loss of that capability earlier on. We start seeing it in utero. There's lots of connections between mom's gut bacteria and the abundance of peptidoglycan producing bacteria and baby's brain development, right? If mom's gut bacteria doesn't have adequate levels of peptidoglycan producing microbes, then there's a chance that the baby's brain won't develop fully, or will be attenuated in some way or the other, whether it's the myelination of the nerves, or whether it's the number of neurons and the number of synaptic regions, all the synaptogenesis, all of those things are dictated in part by peptidoglycan from mom's gut bacteria, right? So if we start thinking about what all can go wrong as we start losing microbes within our system, it really becomes a scary thought, because we're seeing a mass extinction of these really critical functional groups of bacteria. And we keep seeing that. And we've seen patterns now where back in 2019 and early 2020, when the tests we were doing then compared to the tests we're doing now, there's already a measured reduction in the average number of species in just that last year and a half or 2 years, right? Of course, going to the isolation and the pandemic and all that, that probably didn't help the diversity of the microbiome. And so we're seeing this decline faster and faster. And of course, having low keystone species is a big foundational component of losing diversity over time. So dysbiosis, if you look at all of the microbiome studies I've done over the last 10 years that are really well done, correlating or showing causation to disease pathology, when you measure dysbiosis, the two key features that you find that's a great definition of dysbiosis is having low keystone species and thus having low diversity in the microbiome, right? So that's the extent that's important to understand about dysbiosis. It's having low keystone species and low diversity. Now, what happens when you have low diversity is you start losing all of the byproducts that the microbiome is supposed to be producing that are critically important for our function. So those are considered postbiotics, right? Like short chain fatty acids, for example, butyrate, propionate, acetate. I'll focus in on short chain fatty acids in this case because we're talking about the disruption of the mucosal layer and intestinal epithelium. And these are critically important postbiotics that are supposed to be produced by the microbiome. In fact, largely produced by many of the keystone species. So when you have low keystone species, low diversity, you end up at low levels of short chain fatty acids. And when you do that, then you end up with a disrupted mucosa. And part of that reason is because the short chain fatty acid like butyrate is the primary fuel for the goblet cells to stimulate the goblet cells to produce more mucus, right? Produce more mucin to rebuild the layer. So without adequate butyrate production, you're not going to get enough mucin production to rebuild the mucosal layer. So as you get more and more dysbiotic and your diversity goes out of balance and starts to lower, your keystone species are reducing, you're starting to get overgrowth of organisms that eat away at the mucosal layer, and compare that to fewer organisms that can rebuild it. The low level of butyrate production will be one of the final components to why we're not rebuilding that mucin layer effectively, right? So that's the cascading effect, right? It starts with dysbiosis, that imbalance, low keystone species, low diversity, too many microbes now eating away at the mucin layer, and not enough microbes and postbiotics to rebuild it. So you start getting disrupted mucosa, and you start getting translocation of commensals and also opportunistic pathogens and outside microbes all translocating in close to the intestinal mucosa, and that creates a disrupted mucosal immune response. Because remember, I talked about earlier how this inner part of the mucosa is a very important channel for or conduit for communication between the microbiome and the immune system, right? And the immune system that's embedded into the intestinal epithelium, and also the immune cells that are in the basolateral circulation right below the intestinal epithelium. So when you get a disruption in that channel, when you get a huge influx of microbes translocating into that space, it completely disrupts the crosstalk between the microbiome and the immune system. The immune system thinks the body's under attack, that there's a septicemia that's about to happen. And so what tends to occur is you tend to get a huge recruitment of immune cells, innate immune cells, to the region, to the intestinal epithelium layer, to try to defend the body, right? And this creates a dysfunctional gut barrier, because how are those innate immune cells doing their work? They're using inflammation, right? And they're non-specific, as you know, so they will disrupt the cells, your own cells, just as much as they disrupt any bacterial cells or viruses or fungi or any of that. So they'll continuously get recruited to the site of action by the intestinal epithelium immune cells by putting out chemokines like MCP1, for example, that continuously recruits immune cells to this area, because the body keeps thinking it's undergoing sepsis, right? So this becomes a very, very common picture in the vast majority of your patients that are dealing with chronic conditions. They have this disrupted mucosal layer. They have this disrupted mucosal immune response. Now the crosstalk between the microbiome and the immune system is completely disrupted and attenuated, which means that all the other normal immune functions that you need, that's the upregulation of the FOXP3 Treg system and the tolerance system, the upregulation of IL-10, so you're not creating inflammatory responses throughout the body, all over the place, the triggering of the right B cells and T cells and T helper cells, all of that goes completely out of balance when this crosstalk gets disrupted, right? Because the body starts to focus in on this area. Immune cells, innate immune cells, are constantly recruited here. So all the other important balanced immune functions stop occurring at the rate that they should be occurring. Now, when that happens, then throughout the body, where you have latent viruses and other opportunistic organisms, they read those signals, and that's when they start rearing their ugly heads, and they start expressing their virulence factors, right? So now, because the gut mucosa is disrupted and the gut immune system is disrupted, where of course 70+% of all your immune tissue is, when that starts to get disrupted, that has peripheral effect on the immune systems and immune function throughout the body, which then allows opportunistic organisms throughout the body to start actually proliferating, right? So it becomes this cascading effect that occurs. And then as the barrier itself becomes dysfunctional because of the inflammatory attacks near the intestinal epithelium, which eventually breaks up those cells, breaks up the tight junctions between the cells, then you get true translocation of toxins and bacterial components and all that past the intestinal epithelium into circulation, right? And in particular, one of the most egregious endotoxins that translocates through on a regular basis is LPS, lipopolysaccharide, which is produced, of course, by gram-negative bacteria. So that is the basic, pathology. If you understand this and you read all the papers associated with this, and believe me, there's literally thousands of papers that talk through this whole disease pathology of how this happens in this cascading structure, and then what the end result is. And the end result is too much LPS in circulation, and then a chronic inflammatory immune response occurring at the epithelium. And when it occurs at the epithelium, that gets translated to the rest of the immune system. So now you've got chronic inflammation happening in most of the rest of the body as well. And all of the supportive and regulatory parts of the immune system aren't working as well. So now everything that you breathe in and everything that you consume gets a more hypersensitive inflammatory responses, because the checks and balance systems within the immune system, the Treg cells, the interleukin-10, those aren't working as well under these conditions, right? So this individual that starts to see this type of setup or this type of formation in their gut lining starting with the dysbiosis all the way down to this disrupted gut barrier, and then the translocation or endotoxemia of LPS and other toxins leaking through. These individuals start to see all kinds of immune disruptions. They're starting to lean towards an autoimmune response. They're starting to lean towards sensitivities to more foods, to environmental particles, even sensitivities topically to atopic dermatitis and things that can irritate their skin easier. They're, of course, having mood issues because this type of pathology also drives a significant amount of unwanted stress response. And so everything is starting to break down. And then their metabolic system also starts to break down. And what I'll do over the next few slides is show you some review papers, some meta-analysis papers that talks about this particular pathology and how it relates to certain disease conditions. So the first one is this review paper termed beneficial modulation of the gut microbiota. And what they went through a number of studies on this topic. And what they show is that the disruption of the gut microbiota has been implicated in many conditions and diseases, including obesity, inflammatory bowel disease, irritable bowel syndrome, type 2 diabetes, and colorectal cancer. And they, at the end of the paper, after they go through all the pathology that is being revealed out there through all the studies, they show that there's a specific, understanding this specific relationship between the gut microbiota and disease allows us to think about therapies that could be intelligent modulations of the gut microbiome, right? So ways of modulating the microbes to start reversing that pathology, because that whole breakdown system that I showed you can easily be reversed if you start changing the microbes that are prevalent in the microbiome, right? If we start bringing back the microbes that bring back diversity, that bring back regulation, and bring back the rebuilding of the mucosal layers, then all of that breakdown system will start to get reversed. It's all changeable, right? It can all be manipulated. It can all be repaired. And that's part of a big thing that we are focusing on as a company is how do we, number one, detect these dysfunctions, and then how do we utilize microbiome therapeutics to reverse that process. Here's another review paper that looks at the irritable bowel syndrome or inflammatory bowel disease, looking at low diversity as well. And they showed that when they looked at patients who had inflammatory bowel disease, compared them to age-matched cohorts that did not have it, the most consistent observation in IBD is reduced bacterial diversity, right? So having low levels of microbe species, alpha diversity, is a driver or correlative risk that leads to inflammatory bowel disease. And they showed that a number of trials have shown that therapies that correct this dysbiosis, including, of course, fecal microbiota transplants and probiotics, seem to be quite promising because we can start reducing some of the inflammatory processes that are occurring in IBD, right? So fixing the dysbiosis should become step one in any kind of chronic disease therapeutic, because that dysbiosis is likely driving the condition. Here's an example of information on one of the keystone species, that Akkermansia. Akkermansia muciniphila is inversely associated with obesity, diabetes, cardiometabolic disease, and low-grade inflammation. I mean, just think about obesity, diabetes, cardiometabolic disease. I mean, that probably accounts for the majority of your patients, what they're dealing with and what they'll likely succumb to. All of those are inversely associated with this single species, Akkermansia muciniphila. And there are engrafting studies that show that you can actually improve metabolic disorders, you can improve conditions associated with obesity, diabetes, liver disease, cardiometabolic disorders by engrafting or increasing Akkermansia growth. These are animal studies, and there's actually a couple of human studies as well. So administration of Akkermansia under the right conditions could potentially profoundly reduce the development of all these conditions, right? So think about that, the vastness and the complexity of the microbiome. And here it boils down to one species within the microbiome, one keystone strain that has a significant impact in chronic diseases that'll kill 6 or 7 out of 10 adults in this country, right? It's mind-blowing when you think about the role of the microbiome. Here's the other really important keystone species, Faecalibacter prausnitzii. The abundance of F. prausnitzii was decreased in IBD patients compared with healthy controls. We see that in study after study. And in their meta-analysis and their summary and the systemic review that they did of all the publications, they suggest a possible protective benefit of F. prausnitzii against the development of IBD. So using things like probiotics, prebiotics, and all that can increase fecal and bacterial plasminocyte could be really a significant gain, a win in the battle against inflammatory bowel conditions. And so again, single keystone species play such an important role in the disease process of conditions that impact millions of people every single day, right? So these keystone species, we cannot overstate their importance here. Here's another perspective in a write-up looking at epithelial barrier function. The three big studies that they reviewed showed that the gut epithelial barrier dysfunction is involved in processes like IBD, autoimmune disease, and systemic infection. And again, because when you lose that barrier function, you get translocation of all kinds of things, including endotoxemia, which is the translocation of toxins, primarily LPS, but you can also get pathogenic bacteria that can pass by the intestinal barrier and translocate to local lymph nodes and to the liver. And when they translocate into the local lymphatic system and the lymph nodes, primarily the mesenteric lymph nodes, they can trigger autoimmune-like responses. That's now one of the known triggers for conditions like lupus. So it's, when you start looking at all of these different conditions that this same system impacts, it starts to become clear that there's an underlying root cause that's driving many of these seemingly unrelated conditions, right? So we talked about metabolic disease like diabetes, IBD. I'll show you a few other conditions, but these are seemingly unrelated conditions that are all being driven by the same pathology, the same disruption to the mucosa, to the dysbiosis that leads to the disruption to the mucosa, then the epithelial barrier, and then the translocation. Here's another paper that really goes through how the translocation of LPS from gram-negative bacteria in the microbiome plays a role in the inflammatory pathophysiology of depression. So they conclude that the results show that intestinal mucosal dysfunction, again, the breakdown of that intestinal mucosa characterized by an increased translocation of gram-negative bacteria, plays a role in the inflammatory pathophysiology of depression. And I do entire lectures just on this pathology itself. And so this is very clear now. There's no doubt that depression, anxiety, and the severity of depression and anxiety is characterized and driven by leaky gut and endotoxemia that results from the barrier dysfunction, right? And the amount of LPS you have in circulation is directly associated with the severity of the condition, of the depression or anxiety, and all the sickness behaviors associated with it. And in fact, over a 9-year period, a huge study in the Netherlands, following people and their level of LPS and their anxiety and depression conditions, over a 9-year period, they showed that correcting for other chronic diseases, LPS was the single best predictor of the ongoing presence, persistence, and severity of those depressive and anxious conditions, right? So we know that this is driving so much more than just GI symptoms. And that's one of the important things to note from this talk itself, is that when we talk about the microbiome, we talk about the gut, we often lean towards GI symptoms, and we focus in on things like IBS, which are of course very important, but know that the same pathology that leads to IBS is also driving things like depression and diabetes and cardiometabolic syndrome and so on. Here's another one, another seemingly unrelated disease, which is to depression or to diabetes or to autoimmune condition, gastroesophageal reflux disease, right? But also driven by the same common dysfunction. So they show that in the pathophysiology of GERD, abnormal exposure of the esophagus to luminal contents. So remember, luminal contents are supposed to stay in the luminal layer, but if you get that disruption of that inner lining of the mucosa, that inner layer, that mucin 2 layer, you get too much exposure and too much translocation of luminal contents, right? And that leads to chronic mucosal inflammation that is characterized by the release of IL-8, specifically IL-6, TNF alpha, IL-1 alpha and beta. Those are all the characteristic interleukins, cytokines that get generated from that mucosal disruption and that translocation of luminal contents. And they showed that the destruction of the epithelial barrier function was a key part of the formation of the symptomology of GERD, right? So what we think as being too much stomach acid, or people are taking PPIs to reduce that and all that, is not really the driver here. It's this same mucosal disruption that starts with dysbiosis, right? That's driving reflux disease, just as the same way it's driving anxiety and depression. Here's another thing, and there's been a lot of study on this in AIDS patients, because the NIH had identified in a 2014 publication that the biggest predictor of mortality in HIV was not more so than viral load, was the level of endotoxemia that the patients had, right? Because one of the things that occurs within HIV positive patients is an aggressive disruption of the intestinal barrier system because of the upregulation of CD8 positive T cells, right? So those CD8 positive T cells induce all of this inflammatory damage that occurs in the gut lining, and it's called HIV enteropathy. So it's a much more aggressive and faster form of the typical barrier dysfunction that you see in a non-HIV patient, but it's just happening at a more aggressive level, and it's happening faster. And so what they find is that severe mucosal immune dysfunction is associated with the progression from HIV to AIDS, right? So because it compromises the immune system in such a significant way. So remember, I talked about once you start getting that localized disruption of that mucosal immune response, it directly impacts the systemic immune response as well. So when you look at a condition where you have a virus like HIV in your system, the suppression of the immune system from intestinal barrier dysfunction and that disruption of the mucosal layer is a significant driver of compromising the immune response, and then transitioning from having just being HIV positive to having full AIDS, having full-blown AIDS, having the acquired immune deficiency as well. And of course, how long you live can also be predicted by the diversity within your microbiome in the presence of keystone species. There's a number of studies that have looked at people, who centenarians, for example, that live a long time and are relatively disease-free. When they compare the microbiomes, they tend to have the diversity of people in their 30s. One of the factors of getting older is actually a slow reduction in the diversity in the microbiome, and that starts to disrupt digestive processes, immune system, recovery, ability to repair after damage when it comes to tissue and all that. So those are all hallmarks of aging, and a lot of that is driven by that consistent reduction in the diversity of the microbiome over time. So people who are in their 90s and older, who are relatively healthy, who have low or no chronic illness, have lots of energy, are active, when you look at their diversity, they have the diversity of 30-year-olds. Right, so maintaining and building diversity within the microbiome becomes critically important, of course, not only just to reduce those disease pathologies that we talked about, but also how trying to support how long you live, longevity in general. So again, to review, all of these seemingly unrelated conditions, right? So we looked at meta-analysis papers on things like gastroesophageal reflux disease, anxiety, autoimmune conditions, when you have translocation of pathogens into the mesenteric lymph nodes. We looked at things like diabetes, cardiometabolic syndrome, obesity, IBD. Many of these are seemingly unrelated conditions and affecting different parts of the body, right? It's not intuitive if a patient walks in and says, hey, doc, what does my reflux have to do with my diabetes? Or what does my reflux have to do with my depression? The answer typically would be, well, nothing really, because the reflux is happening in the upper part of the GI, and your depression's in your brain, or your diabetes is an issue with your pancreas. But as it turns out, they all have the same root cause dysbiosis, right? It's the same dysbiotic process that leads to that low diversity, low keystone species that ends up leading to the translocation of things like LPS across the intestinal barrier into the basolateral circulation, leading to things like chronic low-grade inflammation and high levels of endotoxin circulating in your system, right? So that disruption of the mucosa, that disruption of the barrier system, that recruitment of the immune cells, the final product from all of that is this endotoxemia and translocation of luminal content, not only adjacent to the intestinal epithelium, but then past the intestinal epithelium and into circulation. Right now, I'll show you how LPS and the translocation of LPS drives disease pathology. So when you look at the clinical manifestations of LPS-induced chronic immune activation, and remember, LPS is an endotoxin. It's a gram-negative bacteria endotoxin. LPS is treated very, very seriously by the immune system. It's so severe in that your immune system actually produces a compound LBP, LPS binding protein, to circulate around looking for LPS to bind it up, take it to the immune cells to create a response, right? So when you have high levels of LPS in circulation, it creates quite a profound immune response in the body chronically. Now, it can do it in localized tissue because LPS is pretty pervasive and can embed itself in many different tissues, including the brain, once it's in circulation, or it can happen systemically as well. It can be driving inflammation systemically. So when you look at the conditions associated with LPS endotoxemia, both correlatively and from a causative standpoint, metabolic syndrome is driven largely by LPS endotoxemia. Things like heart disease, dyslipidemia, so lipid problems, hypertension, type 2 diabetes, dementia, cancers, polycystic ovarian syndrome, non-alcoholic fatty liver disease. All of these conditions have elevated circulating LPS levels as a root cause and a fundamental driver of the pathology of these diseases, right? So I'll show you some examples here. For example, the American Diabetic Association has published a number of papers showing metabolic endotoxemia. Metabolic endotoxemia, if you're not familiar with that term, describes the process of translocation of LPS past the intestinal barrier into circulation, and it's happening largely during eating a meal, right? So when your gut microbiome is disrupted, when you have dysbiosis, you have low keystone species, low diversity, you have a disrupted mucosa, you have a disrupted epithelial barrier system. When you eat food, it generates a lot of LPS because there's die-off and turnover of a lot of the gram-negative bacteria that are sitting in the microbiome. And so they release their LPS into the lumen. And because that luminal content is allowed to leak through because of the disruption of the barrier, you end up getting a lot of LPS leaking into the circulation during the process of digesting food. That's why it's called metabolic endotoxemia or postprandial endotoxemia. And I'll show you, one of our first studies on this, where during a meal, if your gut is leaky and disrupted, then within the first 5 hours, you see the peak of LPS postprandially. But what they've shown in this particular series of studies is that metabolic endotoxemia initiates obesity and insulin resistance, right? So there were earlier studies that showed that people who were obese and people who had diabetes, either pre-diabetic or diabetes, had higher levels of endotoxemia, meaning every time they ate a meal, they got a higher peak level of LPS in their circulation compared to age-matched people that weren't obese and didn't have insulin resistance. So then the question was, what came first, right? Did these individuals have higher levels of endotoxemia because they were obese and diabetic? And if you reverse the obesity and diabetes, maybe the endotoxemia goes down. Or are they obese and diabetic because they initially had higher levels of LPS? And as it turns out, it's the higher level of endotoxemia that comes first, right? The presence of higher levels of endotoxemia drives the initiation and the onset of the pathologies that lead to obesity and type 2 diabetes. And that elevated level of LPS can start at a young age, right? So this can be a pathology that's been brewing in the system for 10, 15, 20 years, and then shows up as you start getting older and your diversity goes down further and further. Not only does it disrupt diabetes in the traditional way by attacking pancreatic cells and disrupting insulin production, LPS can actually cause something called general or central insulin resistance, and this becomes irrespective of body weight. So this is a double whammy in creating diabetes in an individual when you have leaky gut. LPS, the inflammation associated with LPS, the elevation of IL-6 because of the presence of LPS in circulation creates a damage to the islet cells in the pancreas over time. And so it disrupts the ability of the pancreas to produce insulin. That inflammation also disrupts the hormone response to the presence of elevated levels of glucose in circulation. So it disrupts how the brain reads the blood sugar levels. And then this particular egregious process of creating central insulin resistance is a double whammy on these individuals, because what they've been able to show is that LPS can induce low-grade inflammation in the hypothalamic J&K region, and that causes the inability of the brain to read the blood sugar levels, right? So your pancreas could be working okay, it can produce enough insulin, it can respond to the body's need, but the brain can't direct the pancreas to do that because it can't read the blood sugar levels effectively, right? So this becomes central insulin resistance that starts in the brain rather than the pancreas. And the LPS does impact the pancreas as well. So it's a double whammy on its ability to drive disease. This is another very important study called the CardioPrev study. This was, I think, 490 patients over 60 months or so. They followed, and they were looking at biomarkers that were the best predictors of predicting whether someone will go from being pre-diabetic to diabetic. And they really only found one biomarker that was present in the vast majority of people that could predict their movement from pre-diabetes to diabetes, and that was plasma LPS levels, right? So LPS plasma levels was a biomarker that was the best predictor of the formation of type 2 diabetes. And so endotoxemia, again, high postprandial endotoxemia precedes the development of type 2 diabetes in this randomized control trial, this pretty large scale randomized control trial called the CardioPrev study. So it's pretty clear. And we all know that diabetes is really an epidemic that is looming, that is really going to drive lots and lots of global health issues, and probably is driving already lots of health issues within your patients, because the moment somebody has diabetes or elevated fasting glucose and so on, or high A1C, they already become significantly more at risk for other chronic conditions, right? Like heart disease, dementia, cancers, and so on, autoimmune conditions. So at the crux of this formation of diabetes risk is this endotoxemia, this postprandial or metabolic endotoxemia that comes from the disrupted mucosa, that dysbiosis, that disruption of the epithelial barrier function, and the translocation of LPS. Right, so just think about, if we can resolve diabetes, if we can resolve cardiometabolic disorders, if we can resolve reflux disease and depression and all that, or at least we can reduce the risk for all of those conditions among the population. Think about what a significant impact that would be to you, not only your patient's health, but to the global health crisis that we're facing with chronic disease, right? And LPS and endotoxemia are at the root cause of this. There are lots and lots of studies that are showing this over and over again. Even other areas of the body, like the brain, for example, in Alzheimer's, they're finding that lipopolysaccharides from the microbiome have been shown to be, can be enriched in the perinuclear regions of people with Alzheimer's disease in their brain. Where LPS, because of how pervasive it is, once it translocates and in circulation, it can make its way to the brain and trigger inflammatory responses in the brain that lead to the disruption of the brain tissue, and then eventually the beta plaquing that occurs, right? So the LPS is going there and triggering this innate immune response in the brain that's leading to disruption of that tissue. And the same thing happens in Parkinson's as well. I don't have that study here, but Parkinson's is also driven by endotoxemia and long-term exposure of LPS to the enteric and then central nervous system. You get the formation of the alpha-synuclein and the accumulation of the alpha-synuclein and movement of the alpha-synuclein accumulation from the enteric nervous system then to the central nervous system, where you start to see the symptoms associated with Parkinson's disease. It's pretty clear now that LPS endotoxemia is a big driver of Parkinson's and, of course, of Alzheimer's as well. When you're looking at cancer, right, so upwards of 60% of cancer mortality risk can come from cachexia that develops during cancer treatments, during going through the chemotherapy and so on. And the thought around that cachexia was that it was a change in the diet, and it was a chemotherapy that it was affecting the individuals. But this study here of 152 colorectal and lung cancer patients showed that LPS was the key driver of the risk of developing cachexia, right? So they showed that it was not only increase in cachectic mice and in cancer patients, LPS levels, but also strongly correlated with serum IL-6 levels and predictive of death and cachexia occurrence in these patients. So once they start cancer treatment, or even prior to starting cancer treatment, if their LPS levels are high, then they are at much higher risk of developing cachexia and having higher mortality through cancer itself, right? So it's a profound alteration of intestinal homeostasis in cancer cachexia, which is occurring independently of any chemotherapy and food intake reduction. And that's a really, really important part as you start looking at, of course, where does this cancer risk stem from to begin with? It's because of the disruption of the gut mucosa, the endotoxemia, the translocation of LPS, and then now that same pathology plays a role in whether or not cancer treatment will be successful, right? So again, it all flows through together, and there's a number of conditions. I'm not going to go through all of these in detail in the interest of time, but I'll point out a couple, and I can give you all the references for all of these as well. But things like depression, loss of memory recall, mood, appetite disorders, all of these can be shown to be driven by LPS when it's allowed to accumulate and circulate in the system. Even things like hypogonadism, which we're seeing now, testosterone levels dropping significantly year after year in men. There's some statistic, I think in the last 10 years, we've seen almost a 40 or 50% reduction in testosterone levels in men. And one of the reasons we're seeing that is high levels of gut dysbiosis, leakiness in the gut, endotoxemia, because when you look through all the publications on the gelding theory, they show that increased circulating LPS creates a subsequent chronic inflammatory condition that provides a negative feedback loop towards testosterone production. Testosterone production is antagonized by chronic inflammation, which kind of makes sense from an evolutionary standpoint, because if you're sick, if your body thinks you're sick, meaning you have chronic inflammation, high levels of LPS, the last thing it wants you to do is have more testosterone, right? So you don't need that type of hormone surging through your body. You're supposed to be laying down and resting and not having the impact of testosterone. And so when you start to see that the population is becoming increasingly inflamed and having more and more and more endotoxemia, these are some of the other byproducts of having that high levels of LPS endotoxemia. All the conditions we talked about earlier, the chronic conditions, the diabetes, Alzheimer's, Parkinson's, and so on, but it's even driving things like infertility in women, hypogonadism in men, and even things like leptin resistance, autoimmunity, anxiety, and so on. So again, it all starts with dysbiosis, and we define dysbiosis most accurately by showing low levels of keystone species, low diversity in the microbiome, which leads to low levels of postbiotics like short-chain fatty acids. That creates a disrupted mucosal layer, because now you have this imbalance between microbes that eat away at the mucosa and microbes that rebuild the mucosa. Then you get a disrupted mucosal immune response. Now, when the localized immune response in the mucosa is disrupted, that translates to the rest of the systemic immune system as well, because the systemic immune response takes cues from what's happening in the gut, right? The gut is like the central command system for the immune system. And then eventually it leads to dysfunctional gut barrier, and then a leaking in of things like LPS and other luminal contents that drive inflammation. But LPS is a particularly egregious compound that leaks through. And so when we were looking at this basic dysbiosis, how would you go about trying to correct this, right? If you have a patient that has this picture, right, this is what they look like, and I would guess the vast majority of your patients have this picture, right? How would you go about correcting that? So we put it into 3 steps, because it always starts with dysbiosis, and then there's a cascading effect. So to us, you have to first start by repairing the dysbiosis before you try to fix anything else. So we call that reconditioning the gut, which is increasing keystone species and increasing the diversity of the microbiome. And I'll show you how we've done that in a couple of studies to show the data around it. And then once you start establishing higher diversity, more keystone species, or at least higher relative abundance of keystone species, you need to keep reinforcing that ecosystem, right? So you need to keep improving and the stake and the hold by these beneficial organisms, because there's tons of things in the environment that continuously work against these keystone species and work against diversity. Take Roundup, for example, that we're all exposed to on a daily basis. It has a significant impact on diversity in the microbiome. So we need to continuously establish, support a stable population that's increased in keystone species and shows increased diversity as well. So step 1 is reconditioning the gut. Step 2 is reinforcing that new microbiome. And step 3 is then providing the microbiome with the tools it needs to repair the mucosa and the intestinal epithelium. As it turns out, we have very few genes that actually allow us to repair our mucosa and our intestinal epithelium ourselves, right? We actually need the job and the function of the microbes in order to do that. So the resident microbes that are sitting in that area are largely responsible for repairing that system themselves. So we need to bring them back, put them in at higher rates, and then provide them the tools, things like immunoglobulins, polyphenols, and amino acids. And I'll show you why those are important in rebuilding the mucosa and regulating it as well. So we call this the total gut restoration process. This is how we think about reversing that very, very common pathology. So the first thing we did is we did a symbiotic study, which is a combination of a probiotic and a prebiotic. We use, of course, the spore-based probiotics, which is what we've been researching and working with for the last 12 years almost. And then we use oligosaccharide prebiotics to look at, can we recondition the gut? Can we increase diversity? Can we increase the levels of keystone species when you combine this probiotic and prebiotic? And I'll show you, I think there's more significant data. Oh, so here's a general data. So this is the cohort data. What we tend to see is, and the gray bar here is the post 3 weeks of treatment with the probiotic and prebiotic. We see a significantly higher amount of bifidobacteria, many of the bifidobacteria species, so Adolescentes, longum, and so on. So we're getting higher levels of those keystone species, 40, 50% increase there. We're seeing upwards of 2 logs increase in lactobacilli. And it's surprising to us how many patients with their microbiome analysis show no detectable levels of lactobacilli in their gut. And a healthy gut can have upwards of 3 or 4% of lactobacilli. So it's really, really interesting to see that so many patients, show with having almost no detectable levels. So it's great to see that we can increase the lactobacillus levels as well. And then we also looked at keystone species like Faecalum bacteria. This was super exciting because we're seeing a 2 log increase, right? That's not a 50% or 100% increase. That's a 100-fold increase. Right, we're going from 10 to the 9 CFUs per gram of stool, all the way to 10 to the 11 CFUs per gram of stool, which is actually where you want Akkermansia to be, around 10 to the 11. So it's a huge increase in Faecalum bacteria. And in individuals that had decent levels of Akkermansia, we didn't see much change. But in individuals that had low levels of Akkermansia, below 10 to the 7, we saw a huge increase in Akkermansia. The total cohort data had some pretty decent Akkermansia levels already, so they seem to not have a huge change overall, but the few individuals that had low levels of Akkermansia saw a very significant change. So we felt pretty confident that we can make the right changes within the microbiome. So we wanted to see, does that also then affect the postbiotic production, right? Because really that's the next step that goes wrong. Once you lose diversity, lose keystone species, short chain fatty acid production goes down the tube. So we were looking at that as well. And here's what we see. This is the purple line here is the total short chain fatty acid. And then you've got acetate, butyrate, and propionate. And what we see there after the control period, which is where they're not taking the supplements, or whether the supplements are not being supplemented. And then we go into the treatment phase, you start to see a huge increase in the generation of short chain fatty acids, right, including butyrate. And so you see that from each of the donors, we saw huge increases in short chain fatty acid production, very measured right at the time of starting the prebiotic and probiotic. And we see about an 80 to 140% increase in short chain fatty acid production. So that was super exciting because then we're seeing an increase in diversity, we're seeing an increase in keystone species, and we're seeing the byproducts of that, which is increased postbiotics like short chain fatty acids. And here's the Shannon index data on the diversity. We saw a huge increase. So the higher the number here, the higher the diversity. So we were seeing, if you look at their pre numbers, 12.4, 11.4, jumping up to 14 and 13, 11s jumping up to 18 and 15, 13s jumping up to 15 and 18. That's a huge measurable increase in the diversity of these individuals' gut microbiome. So it was really quite exciting to see that. So then we started understanding that, okay, we are making that impact. And then we started studying other disease processes that would be impacted by that change in the microbiome. And sure enough, we're seeing lots of great clinical outcomes, like in acne, for example, or elevated triglycerides or rheumatoid arthritis. So we started doing all kinds of other studies with those endpoints to see if we increase diversity, increase keystone species, and short chain fatty acids, will we see an improvement in those clinical conditions? And sure enough, we're starting to see that as well. I didn't put all those studies in here in the interest of time. But so that first part, the probiotic part and the prebiotic part, is the recondition and rebuild, recondition and reinforce part of it. And then now as the diversity increases and as the keystone species increase, there's a few tools that can really help when you add into the microbiome to help rebuild the mucosal layer and reform the mucosal immune response. One of the ones that we love to use is bovine IgG. In particular, we like this because it's been studied quite extensively in HIV enteropathy, showing a significant ability to reconstruct and reconstitute immune response in the gut lining and then systemically as well, and also improve intestinal repair, improve duodenal function, improve even CD4 positive lymphocytes in HIV, which is really quite fascinating, right? So we use bovine IgG a lot. It's also been studied in other areas like pediatric ulcerative colitis. It's also been studied in C. diff infections that, of course, is driven by a significant disruption to the mucosa and to the microbiome because of the presence of antibiotics. So it can help significantly in those cases as well. So bovine IgG is really important. Polyphenols are the next tools because polyphenols will reduce inflammatory responses that are occurring at the gut lining itself, right? By inhibiting the activation of NF-κB, which is a cascade that occurs when LPS is present at the intestinal epithelium. It can block J&K stress activated pathways. It protects against experimental colitis, reduces the risk of IBD in a number of studies. So polyphenols also feed Akkermansia. That's one of the things that Akkermansia likes to consume. So polyphenols become a very critical part of rebuilding the mucosa because Akkermansia is one of those very important keystone species that plays a role in triggering the reformation of mucin, right? So you need the bovine IgG and the polyphenols. Also, these citrus polyphenols have been shown to improve butyrate production, reduce fecal calprotectin. So it creates all kinds of improvements within that intestinal epithelium. Very important component of rebuilding the mucosal layer in the intestinal epithelium. Another really important one that has been largely ignored are these 4 key amino acids, right? L-threonine, L-serine, L-proline, and L-cysteine. In this study in particular, and there's a couple other studies, they showed when you experimentally damage the intestinal mucosa, when you have these 4 amino acids, it increases colonic mucin synthesis by 95%, because these are the critical building blocks of the mucin layer, right? So if you don't have adequate intake of these amino acids, then you have all the triggers to rebuild the mucin layer, you can't rebuild it effectively because you don't have the building blocks. So this becomes a very critical component of that rebuilding process as well. So this brings me to the end of my talk. So the way, the general message here is that all of these seemingly unrelated pathologies, right, that are driving conditions like reflux, anxiety, long-term conditions like Alzheimer's, Parkinson's, of course, depression, diabetes, metabolic syndrome, all of these seemingly unrelated conditions, all when it comes to the microbiome have a very similar root cause disruption. And that is that low diversity, low keystone species, low levels of postbiotics, eventually that disrupted mucosal layer, the translocation of luminal contents, the induced inflammatory response because of that, and then the complete disruption of the barrier, and then translocation of luminal contents into circulation itself. And the most particularly egregious one is LPS, lipopolysaccharide. And in our view, and we are seeing it now not only in clinics, but we're seeing it in research as well, that there's a way of reversing that pathology by starting with addressing the dysbiosis, the low diversity, low keystone species, increasing postbiotics, and then throwing these critical repair tools like bovine IgG, polyphenols, and amino acids to help the microbiome rebuild those layers. So this becomes, to me, foundational for the vast majority of patients, because foundationally, most of them are probably suffering from the same disruptions and dysfunctions. So hopefully that made sense, and that gave you some insight into how microbiome dysbiosis drives disease conditions. So Akhil, if there's time, I'm happy to take questions.
Okay, wonderful. Thank you, Karen. That was an amazing presentation. We're getting a lot of messages in the chat of gratitude, and so just thank you for such a great, introduction and overview. And yes, we do have a lot of questions, so maybe we could. I'll tell you some of those now.
Okay.
So question from Dr. Deepika Minal, who's one of our new Sutter docs in Santa Rosa. Love your gut lining pictures. Is it possible to use those with patients, like for patient education?
Yeah, absolutely. So in fact, we'll happy to ship you a desktop size of it, which actually is you can write on it with a dry erase marker. So we have a lot of docs that use it in clinic and in their office as they want to explain what's happening to their patients. You can write notes on it for your patients and all that. Then your patients can take a picture of it, and then you can just erase it. So if you want to send through the program your address, more than happy to ship you one of those, or a couple of them if you want.
Okay, perfect. And then, Karen, if you can end your screen sharing so people can see your full face and stuff, that would be great.
Oh, yeah.
Okay, so question about, can you have too many of a keystone species where it starts to have a negative impact? And also, can you overdo it with prebiotics?
Yeah. So great question. So there's some data, early data, that really high levels of Akkermansia can drive some autoimmune responses, right? And I can see why that would be, because Akkermansia, part of the way it triggers mucosal repair is by actually eating away at the mucin layer. But when it eats the mucin layer, it produces a byproduct that turns on one of the genes in our system called the MUC-T gene, which then triggers the repair and rebuilding, right? So its process of digesting the mucin layer actually helps us rebuild. But I think then if you have low short chain fatty acids and you have really high Akkermansia, it can lead to a net disruption of the mucin layer, because you don't have all the postbiotics required to rebuild it, even though Akkermansia is triggering the rebuild. So that's the only one that we've seen some preliminary data that can be a problem if you have too much. But I think it's not just too much of that organism. In my view, it's not. It's more or less a situation of having not enough of the other organisms, like the Faecalibacter and the Bifidolongum, that produce the short chain fatty acids that are required to respond to the Akkermansia signaling to rebuild. So in general, though, I mean, we've done now 8,000 microbiome tests. And we've looked through it. We have an awesome data analytics team that's going through the data all the time. We have not ever seen anyone with too high of keystone species. If anything, the vast majority of people have very low levels to a point where they're undetectable. It doesn't mean that it's not there, but it's their concentration is so small that the chance of picking them up in that stool sample is low. So sometimes we don't even detect them. Now, can you overdo it with prebiotics? I think you can. So I think if you are very dysbiotic already, there are lots of microbes that are dysfunctional bacteria that can utilize prebiotics and produce non-beneficial compounds like hydrogen gas, methane gas, and so on, that can have more inflammatory damage to the gut, right? So if you are dysbiotic and you use a lot of fiber and lots of prebiotics, it can lead to the formation of those less favorable compounds. So the prebiotics we like to use early on are oligosaccharides in particular, because certain types of oligosaccharides, especially the highly complex oligosaccharides, are relatively specific to the types of microbes that they can feed. So they feed many of the keystone species. So we like, before taking a patient that has gut issues and microbiome diversity issues, before starting them on high fiber and resistant starches and all that, we like to actually give them prebiotics like oligosaccharides first for a period of time to increase the diversity in the microbiome, then bring in more fiber and other soluble, insoluble fiber intake. Hopefully that makes sense.
Yeah, that was perfect. So actually, your offer to send the materials has created like a firestorm of messages. So maybe is there a person within the company that I can put an email address in so people can directly send an email to that person rather than putting everything all over the chat?
Yeah, absolutely. Do you want me to give you that
Yeah, if
first
you could
now?
just tell me that, yeah, we'll put it into the chat. So people
Yeah,
should send their info there.
let me grab. So I think Ali Vasquez, who heads up our events, she can direct it. So her email is pretty easy. It's alvz at novozymes.com, novozymes.com. So it's alvz at novozymes.com. Most of
Okay,
us now have Novozymes email addresses because I don't know if
great.
you guys are familiar. We were acquired by a large Danish biotech company in January of last year, Novozymes. So now we have this amazing, strong research and development partnership with them as well. So, which is very exciting. So
Great.
lots of cool things coming out.
Okay, perfect. Okay, great. So yes, if you would like that information, please message her. So next question: which are there foods that support akkermansia? Is that present in the diet?
Yeah, so as I mentioned, polyphenols really support akkermansia. So polyphenols from berries in particular, so consuming somewhere around even as little bit as 5 to 10 grams of berries can have a measurable impact on polyphenols. And that's not much, right? That's a tiny amount. But really what you should be consuming is a diversity of colored fruits and vegetables. All of those polyphenols in the colored fruits and vegetables, especially like the category of polyphenols called carotenoids, those actually really feed akkermansia. And the other way of increasing akkermansia, which is not talked about as much as it should be, is by fasting.
Mhm.
So doing some degree of fasting, whether it's an intermittent fast every day, 14, 16-hour fast every day, or 24-hour fast every 4 or 5 days, whatever you do, if you add in a period of time of fasting throughout your routine, you will increase akkermansia. So polyphenols, fasting, akkermansia is happy.
Perfect. Thank you. Yeah, and I wanted to add also, the red polyphenols as well have been shown to be helpful for akkermansia. So like the cranberry, the pomegranate, also
Cherries,
red rice,
Mhm.
red quinoa. Those are good as well. So in terms of the diet. Okay, so question is, if someone does need to take antibiotics or IV antibiotics, what do you recommend? Does it change your recommendations in terms of recovering?
Yeah, it does. We have now for the last almost 6 years done this antibiotic protocol where we go really strong with a combination of spore-based bacteria and Saccharomyces boulardii, because at the end of the day, right, the studies are pretty clear that what happens when you take your first dose of antibiotic and then with every subsequent dose is within the first 3 to 4 hours you get almost a 90% reduction in the total bacterial count in your microbiome, which is really quite profound, right? Everything gets brought down, but it comes back up, right, relatively quickly. The problem is every time it all comes down, what comes back up faster is changing with each subsequent dose of the antibiotic. Because if you think about the gut microbiome, one of the regulators of the gut microbiome is lactic acid, right? The pH dictates which organisms can really proliferate and which ones don't proliferate as much. So things like fungal species and a lot of the potentially pathogenic organisms don't do well in a low pH environment. So when you have all of this lactic acid producing bacteria, they're regulating the growth of those organisms. But when you take a dose of antibiotics and everything comes down, lactic acid production shuts off. Now the pH in the gut is higher. It gives a better chance for the dysfunctional bacteria to come back faster, right? So that happening 10 days in a row through a single course of antibiotics creates this total disproportion of microbes by the end of it. And you can see that dysbiosis up to 2 years after the course of antibiotics is done. So our goal when we're taking antibiotics is to use the spore-based bacteria that, number one, can still function in the presence of antibiotics with a combination of Boulardii, because one of the key things that they do is they produce lactic acid. And they will do it during, even when antibiotics are in the system, and they will also competitively exclude the overgrowing egregious bacteria. We actually published a paper in 2020 showing that when a gut, and we use a gut modeling system for this, when the gut is disrupted by an antibiotic, we can reverse the course of that by adding in the spore-based bacteria. So we go high doses with the spores, upwards of 10 to 15 billion, and we do about 5 billion CFUs a day of the Saccharomyces boulardii, and we do that for 3 times longer than the course of the antibiotic. So if that was a 7-day course, we do that for 21 days, and then we start bringing in the prebiotics and all that again.
Okay, perfect. Just to highlight, yeah, you mentioned using the spore-based probiotics and then the Saccharomyces boulardii, which is a beneficial yeast, so it's not affected by antibiotics.
Yeah.
And one of our clinicians is also bringing up that study that you probably saw about how the post-antibiotic use of probiotics led to worse, results in terms of recovery of the microbiome. So do you have comments about that?
Yeah, and I was actually so glad that that study was done, because that's one of the things that we had been talking about for some time is, and keep in mind, what they were using is a mimic of the standard, what I call kitchen sink probiotic, right? When you just throw a whole bunch of different lacto and bifido strains together at 50, 100 billion CFUs. What they were able to show is when you use that kind of probiotic, which is your typical one you'll find at Walgreens, CVS, and so on, what you're actually doing is creating a competition for binding sites for your endogenous lacto-bifido strains, right? So that those strains are coming in and they're actually utilizing the binding sites, and you're creating competition for the endogenous strains to come back. Using transient species like Bacillus and Saccharomyces has a completely different effect, because the transient species are actually there to support the regrowth of your endogenous organisms. And that's one of the key things that we showed in our paper, is not only do we start to reverse some of the immune pathology that occurs when you have antibiotics disrupting the gut microbiome, but you also actually increase the recovery of those endogenous species. So yeah, I would not recommend using a conventional multi-strain lacto-bifido product when trying to recover from antibiotics.
Okay, perfect. Thank you. So question about, is the benefit of the probiotic and prebiotic treatment sustained after the patient stops taking them, or is the benefit seen only while they are on the supplements?
Yeah, there is a period of time where it sustains for some time, and a lot of it depends on the patient's lifestyle, right? So if they've taken the prebiotic, probiotics, they've increased their microbiome, they've improved it, and then at the same time, they're improving their diet, they're increasing the diversity of foods they're taking in, they're increasing the dietary fiber and things like that. Those patients, when they come off the probiotic and prebiotic, can maintain all of the beneficial aspects of the microbiome for much longer. But a lot of patients don't have all of that beneficial lifestyle component of it, right? So we find that typically your average patient, if they come off the prebiotic and probiotic, typically in about 3 months, 2 to 3 months, you start to see some of the reversion effects if their lifestyle is not really healthy. So what we tell patients typically is, when you get to a point where you feel really good, your system's working the way you want it to work, you actually go to an intermittent use of those things. You want to get in 1 or 2 doses a week, for example, continuously. Not something they need to necessarily do every single day, but getting some exposure to it on a somewhat regular basis makes sense for most people.
Okay, perfect. So we have a practitioner wondering that sometimes seeing very high levels of butyrate, very high levels of short chain fatty acids that don't correlate with the clinical picture. Could it be like acute phase response or some type of inflammatory, process where it's abnormally high?
Yeah, sorry, can you repeat that question?
Oh, yes.
Part of it,
so sometimes seeing very elevated levels of short chain fatty acids and butyrate, where could that be something negative that's triggered as a result of acute phase reaction or inflammation, or is it always just positive even though if they're very high?
So it's actually a very interesting question, because it depends on where you're looking for the short chain fatty acids, right? So there is a counterintuitive process that's occurring when you see high levels of short chain fatty acids in stool. So this actually created a bit of a confusion in the research community, because it was starting to become clear in animal model studies that butyrate, for example, was really important for metabolic health, right? It plays a huge role in gut-brain communication and leptin response, adiponectin response, and so on. So then the idea is that people who are overweight are likely producing less butyrate, and people who tend to be lean and have healthy metabolic response are producing high levels of butyrate and other short chain fatty acids. But then a couple of studies came out that showed that obese individuals actually had higher butyrate levels in their stool than lean individuals, right? And then the question became, wait a minute, we thought overweight people made less butyrate, so why did they have more in the stool? The difference there is butyrate in the stool, you're measuring butyrate that didn't get absorbed or utilized properly, and it's coming out as an excretionary product, versus a lean individual whose butyrate was probably more utilized in the system. So it depends on whether or not the butyrate, where you're measuring the butyrate, and what that indicates, right? So having high levels in the stool indicates that there's something else wrong in the gut where you're not utilizing the butyrate appropriately. And so more of it is coming out in the stool and can be measured in the stool. So I would say that in response to that question, if they're talking about measuring butyrate high production in the stool, then it is indicative of some sort of acute phase problem that's occurring where the system is not utilizing butyrate appropriately, and that's why you're seeing high levels getting excreted out. And it's not an overproduction of butyrate by any means. It's because something is going wrong where you're not utilizing properly.
I see. Okay, got it. So so that's like a loss of butyrate in the stool because it's not being utilized correctly.
That's why you see more of it coming out. Yeah,
okay.
It doesn't mean you're producing more of it. It means that you're actually utilizing less.
I see. Okay, got it. Great. Okay, question about, in addition to fasting, is eating fewer meals through the day in a time-restricted eating pattern also beneficial for keystone bacteria?
Yeah, absolutely. Yeah, there's so much good research on time-restricted feeding, on obesity, metabolic syndrome, longevity, cellular mitochondrial repair and all that. So time-restricted feeding is absolutely an amazing, easy way of significantly improving your patient's health and outcomes. So yeah, absolutely. And it increases the diversity in the microbiome.
Okay, perfect. So a lot of questions about measuring LPS, and are there ways in traditional labs to measure LPS?
Yeah. So unfortunately, there isn't a great commercial way of measuring LPS. One of the problems with LPS, when you pull it out and get the serum out, it lasts about, the half-life is about 4 hours, unless you freeze it at -80. And of course, it's not practical to freeze a sample to -80 in the clinic. And so we can do it in research because we can take all the samples and freeze them at -80 and then run them all at the same time through a simple ELISA method that's widely available. But just that practicality of the half-life makes it hard. However, there are a couple of labs like Vibrant and Cyrex that have an immunological measure of either, Cyrex, for example, has an antibody measure of LBP, that's LPS binding protein, which is indicative of elevated LPS, because when LPS goes up, LBP goes up. But I think Vibrant directly measures LPS antibodies. And so that's another way of looking at increased LPS as well. But one of the ways that I like, and we kind of use this in some of our research, is using surrogate markers as well. So surrogate markers are the immune responders to the presence of LPS, in particular IL-6, IL-1 beta, something called soluble CD14, or abbreviated SCD14, and then TNF alpha. So if you look at just those four chemokines and interleukins, so IL-6, IL-1 beta, soluble CD14, TNF alpha, when those are elevated significantly, it's typically driven by endotoxemia. That's a hallmark of endotoxemia. And one fun way you can kind of do it to look at that, actually the endotoxic response, is to have your patients come in fasted, pull a sample, and then have them go out somewhere and have a meal, especially a high-fat, high-caloric meal, and then have them come back in 4 to 5 hours after that meal and pull a second sample. And what you'll see when you send them out is you'll see a delta in how the levels of all of those inflammatory markers. That would be very, very indicative that that patient went through an endotoxic curve where they had high levels of LPS after the meal.
And can those tests be done in a regular lab, like the IL-6 and the ones you mentioned?
Yep. Yeah, those are all can be part of most immune panels. They're typically not your standard immune panel, so you'd have to request them. But I believe LabCorp and all have those four for sure.
Could you name them again? A few people are asking for those four.
Yeah, so the ones would be IL-6, And IL-6 is so important to measure on a regular basis anyway. I know most clinicians are in the habit of measuring HSCRP, which is a good indicator. But HSCRP doesn't necessarily get impacted by some of the endotoxic immune pathways. So you might have normal HSCRP, but have really high IL-6. And IL-6 is a quintessential inflammatory. It can have anti-inflammatory effects depending on certain responses, but for the most part, it's an inflammatory responder. I'll give you one example of how important it is. There was a large-scale study during COVID called the Boston-Dublin study, where the two groups between Boston and Dublin were looking at biomarkers that were really predictive of what a patient's outcome was going to be with COVID. And they found IL-6 and IL-10 were the best markers. If the patient had elevated IL-6 at onset of symptoms, then their risk for being hospitalized and then even dying was much higher than having non-elevated IL-6, right? So that's a great marker for chronic low-grade inflammation. So IL-6, IL-1 beta is particularly egregious because IL-1 beta doesn't need to be expressed only by immune cells. It can actually be expressed by endothelial cells as well. And that's why IL-1 beta is the next big target in the pharmaceutical research around cardiovascular disease, because what they're seeing is all of that endothelial inflammation is driven by constant expression of IL-1 beta by endothelial cells triggered initially by immune cells, right? So IL-1 beta is significantly elevated in people with LPS endotoxemia. We saw in our first publication on the spores and LPS endotoxemia that we brought down LPS and IL-6 and IL-1 beta very significantly in 30 days. Soluble CD14 is the third one, and then the last one is TNF. TNF alpha is a good marker as well.
Okay, perfect. Thank you. So question about oligosaccharides. So the ones that you mentioned, do they work similarly to FOS, which is fructooligosaccharides? And they're asking if fructooligosaccharides can feed Citrobacter or pathogenic bacteria. So how is that correlated?
Yeah. So yes, the ones we work with are a combination of fructooligosaccharides. In particular, the ones we like are the ones that come from kiwi. There are two sources of this from New Zealand that has a lot of great studies on it, on the microbiome, on changes to keystone species. So we really like that fructooligosaccharide from kiwi. And then we also work with xylooligosaccharides that can come from corn cob, the inside part of the corn cob. And then we also work with galactooligosaccharides. And so we tend to work a combination of them. Most oligosaccharides won't necessarily feed pathogenic bacteria. They just don't have the enzymatic capability of degrading the complexity of the oligosaccharide structure, right? Because if you just think about this natural diet as you get these oligosaccharides into your diet, all of it tends to go to the large bowel, to the predominant species within the large bowel that over time have developed enzymatic processes to break down these complex structures. So most pathogens don't have the capability of doing that. So I think you can feel pretty safe giving a patient fructooligosaccharides and feeling pretty confident that it's not feeding pathogenic organisms. We've seen I've not seen any research that indicates that it can feed it at any significant level.
Okay, great. Thank you. So question about, once you get your microbiome into a healthy state, can a healthy diet rich in fiber and prebiotic foods be enough to maintain it, or do you recommend continuing a probiotic supplement?
Yeah, depending on the probiotic supplement. So to me, the transient spores are critically important for continuous exposure, and that mimics nature, right? So the way we're designed to be in constant osmosis with the microbial world around us. We're supposed to be gaining exposure to microbes through food, through interaction with nature. And so there are lots of organisms that have developed this transient capability where we're continuously being exposed to them. They go in the gut, they stimulate responses within the gut, especially immune responses. Some of them can compete against pathogenic organisms and kind of correct some of the dysbiosis in the microbiome, and then they leave, right? So they don't stay very long. They typically stay for 1 or 2 weeks. So that continuous exposure seems to be important because that is the exposure that is typically lost when we live in this hyper-sterile environment. and we see that the lack of microbial exposure over time leads to immune dysfunctions and all kinds of other risks. So to me, having these transient organisms like the spores and Saccharomyces on a regular basis becomes really important. I've been taking them every day for 12 plus years. And I find that during periods of time where I stop taking them because I forget or I'm traveling and I forgot to bring them with me, I start to feel the effects of not having that continuous exposure.
Okay, perfect. So question about any correlation between autism and ADHD with leaky gut, and how early of an age can one develop leaky gut?
Yeah, that's a great question. So as it turns out, when babies are first born, their guts are pretty leaky to begin with, right? So until their microbiome becomes relatively established, which usually takes right around 2 years, their guts tend to be relatively leaky, but they don't have a lot of gram-negative bacteria in the microbiome yet. The predominant organisms tend to be gram-positive, and they tend to have lots of bifidobacteria and so on. So they're not producing a lot of LPS either. So it's okay if the gut is leaky at that time because they don't suffer from a lot of endotoxemia. But as they go between the ages of 2 to 7 and the microbiome is becoming much more established and they're starting to imprint signatures of their permanent microbiome, that's when you start to see lots of gram-negative bacteria showing up, which means that you're going to have more and more LPS exposure, which means that leakiness in the gut can have a profound effect. So I think clinical leaky gut is likely occurring in people over the ages of 5, 6, or 7, right? And that's when you start to see all of the correlative conditions that are driven by LPS endotoxemia. You start to see behavior disorders. You start to see, allergies and immune conditions popping up. Of course, you can see that in younger kids as well, but you start to see asthma and all that really kind of taking a hold, food sensitivities and all in these kids at around that age, at 4, 5-ish years old. Now back to, so I think clinical leaky gut would start around that time, around when your more permanent microbiome is being established and more gram-negative bacteria are establishing themselves, because then you have more LPS. The first part of the question is, does leaky gut play a role in autism spectrum disorders and ADHD? And the research indicates that it likely does, but mom's leaky gut is the key, right? So gestational stress and inflammation seems to be one of the bigger drivers of the potential for developing autism spectrum disorders and ADHD in the baby, and that's just during gestation and with mom's gut. There's a couple of pathogens that are also directly associated with developing risk for spectrum disorders, and that's these pathogens tend to be present in mom and then transfer to the baby. Clostridia boltae is one of them, and Clostridium tetani. Both of those clostridial species tend to be quite present in kids that present with spectrum conditions. So when you look at a family, and if you have 4 kids in the family and one child has spectrum disorder symptoms, and the other 3 children don't, when you look at their microbiomes, the one child that has the spectrum disorder symptoms is the only one that has high levels of the Clostridium boltae and tetani. So there seems to be a very close correlation between that pathogen, gestational inflammation, gestational stress, and then the expression of spectrum disorders.
Okay, wow, very interesting. And I guess a related question, how do you support child born by C-section, and also if they're not able to be breastfed, lack of breastfeeding?
Yeah, interestingly enough, if you have any patients that are about to give birth and if they end up having to do a C-section, the studies on the, using the vaginal secretions and wiping the baby's mouth and nose area and all right after birth seems to be really promising, that you can dramatically reduce the negative effects of C-section birth by doing that, right? So that's, putting in sterile gauze into the vagina, and then once the baby's born, at some point in the first couple of days, taking that out and then wiping those secretions on the baby's mouth and nose and area like that. So that's one thing. But of course, what happens then if it's, few years now after the baby's born? What we tend to see is that one of the big problems of the C-section birth is the first organisms that start to establish are organisms not ones that are found in mom's fecal bacteria like bifidobacteria, but instead it's the organisms of the people in the room, right? So the most prevalent organisms of the people in the room, which tend to be things like streptococcus, staphylococcus, E. coli, and so on. So then the question becomes, can you start to change that effect and increase the right beneficial bacteria within those children? And within the first 6 months, if you use bifidobacteria in a C-section baby, in particular Bifidobacterium infantis, right, it can dramatically reduce any of the negative occurrences of C-section birth. But it really only works in the first 6 or so months. You could probably go up to a year. So if a baby's been born in the last 6 months and with C-section baby, get some Bifidobacterium infantis in them. That can really reestablish the right pathway for the microbiome. Say it's 3, 4, 5 years later, or even they're adults now, then you'd want to go through that gut restoration protocol that we talked about, because they're likely dysbiotic. They have too many opportunistic organisms, too many organisms eating away at the mucin layer. So you want to get in the prebiotics, the probiotics, the mucosal rebuilders. For those individuals, it's back to the basics of repairing the gut.
Oh, okay. So with Bifidobacterium infantis, do they have to be breastfed for getting benefit of that, or not necessarily?
Not the supplemental version. Obviously, breastfeeding is super ideal, right? It has all the oligosaccharides. You need over 200 different kinds to help establish the right types of bacteria. And of course, you get good bacterial exposure from the breastfeeding as well. But if for some reason mom cannot produce enough and she's not breastfeeding for whatever reason, the infantis still can be used without the breastfeeding. And there is a infantis strain that was developed at UC, I think it's UC Davis.
UC Davis, you're right.
Yeah, right. Which has lots of great studies on it, and super effective in that first 6 months.
Okay, great. Well, thank you so much, Kiran, for spending the time today. Really fantastic presentation. In terms of like a follow-up website, if people want to learn more, would you direct them to the main Microbiome Labs website, or?
Yeah, absolutely. So, come visit us at microbiomelabs.com. We, of course, put up lots of resources and tools there. If you have an account with Microbiome Labs, then you can go to area behind the front part of the website where there's far more resources. So we have all of these resource tools and write-ups and white papers and all that to really help our clinicians understand the impact of the microbiome in many different aspects of clinical practice. So there's lots of tools that if you have an account and you can get access to the back end of it. And then also, please reach out on social media. On Instagram, I'm Kiran Biome, KIRANBIOME, on Facebook as well as Kiran Krishnan. So reach out anytime. I love to connect, try to provide people with resources, and then I also try to post when I'm doing talks and all that on there as well. So more than happy to connect with people and engage, and really appreciate this opportunity, Akhil. It was great to meet you. I think when was it, this last September-ish, right? October, yeah. Yes. So thank you for coming out. It was great to meet you in person, and thank you for everyone for hanging in here and listening to the talk.
Yes, thank you again, Kiran. A lot of messages of gratitude coming in. So thanks for spending some of your Saturday with us. I really appreciate it.
My pleasure. Take care.
Okay. Okay, now I'm going to introduce our next speaker, Dr. Wendy Reeve. She's one of our own Sutter Health integrative medicine doctors. So Dr. Wendy Reeve started out in electrical engineering, although she's always had a passion for health and wellness. And during a downturn in her industry, she had the opportunity to explore this passion and complete naturopathic medical degree training in Arizona. And while she was a student, she saw the effects of naturopathic medicine in improving health, but she also saw how few people were aware of it or even had access to it. And so she decided to become an MD to reach a broader patient population and provide a more comprehensive solution to patients. So she attended the University of Arizona in Tucson, where she was inducted into both the AOA and Gold Humanism Honor Societies, and then completed the Integrative Medicine Distinction Track. She then went on to complete a 3-year residency in internal medicine at Oregon Health and Science University. And after a brief stint in her own practice, she found Sutter Health, and she's at our IHH clinic in San Francisco. So please join me in welcoming Dr. Wendy Reeve.
Thank you, Akil. Can you hear me okay?
Yes.
Okay, fantastic. I'm going to share my screen here. Okay. You can see that okay?
Yes.
Fantastic. Well, hello, everyone, and I'm welcome to the seminar today. I'm happy to be here to talk about something that I think has been front and center for so many of us especially over the last couple of years, and to remind us of some, easy, accessible tools and strategies of how we can build resilience to stress. I have no financial disclosures or conflicts of interest. Okay, so we're going to start off with a pop quiz. So who do you think has more stress? And you don't necessarily have to respond to this because it's going to be a pretty quick, just what do you think? Well, like any good pop quiz, it's actually a trick question, right? Because what we're seeing is the response to stress and stressors, not necessarily the stressors themselves, right? So how do we know that they both have stress? Well, because they're both living. If you're living life, you have stress. We hear a lot about, reducing stress and trying to minimize stress. And I'm here to say that that's probably not attainable. There were a couple of psychiatrists, Holmes and Rahi, who did an extensive study to look at, what caused stress in life. And this is a word cloud. They assign different, levels or values to each thing. And this word cloud kind of represents that. And of course, things that you would think of, death of a spouse, very stressful, of course. But what I want to point out is that even happy things, right? Vacation is on here. Retirement was fairly high on the stress. Marriage was definitely high, new child. So even happy things can be stressors in our life. Well, are there any beneficial aspects of stress? And of course, we know about the fight or flight response, the sympathetic response, right? So if a bear is chasing us, that short-term, epi-norepi response, allowing us to get more blood to our muscles, more oxygen to our lungs, everything to help us run from the bear is going to be helpful. Additionally, there is something known as the Yerkes-Dodson law. This is something, these were two investigators back in, I think, 1908, they came up with this. They were doing studies on mice and stressing these poor mice to different degrees, and found that, there was kind of this sweet spot in terms of learning difficult tasks where a certain amount of stress was actually helpful in learning that difficult task, but too much would definitely be detrimental. Simple tasks were a little bit different. Those, stress didn't affect as much. Now, I know that, through the years, they've tried to reproduce this in human studies with not always consistent results, but this Yerkes and Dodson laws, well, as it's called, has become a law in the world of psychology. This was actually a study that did look at the stress or the response of stress in humans, and this was a 2009 study where these researchers were looking at people's long-term stress response to a single traumatic event, something like 9/11 or a natural disaster. And what they found is that people could be generally grouped into one of four categories. The best, if you want to look at it that way, would be people who stressed, had the response to the stress and then came back down, with a fairly reasonable amount of time to either their baseline or even improved beyond their baseline. There were another two groups that maybe took a little bit longer to get there, or maybe didn't quite get back down to their baseline. And then there was a group that really just had long-term chronic stress. And these are the people, both in chronic stress and the blue line, the recovery, that don't ever get back to that baseline. And these are people that are going to be at higher risk of chronic disease. Why is chronic stress so bad? Well, we know it's associated with so many different conditions, so many chronic conditions: heart disease, obesity, diabetes, can affect our brains with Alzheimer's, irritable bowel syndrome. Yes, we just heard a lot about the gut, and the gut-brain connection is so tight. And chronic stress and anxiety is going to disrupt our digestive system. It can affect our immune system, make us more susceptible to infections. It certainly makes us more sensitive to chronic pain. It's associated with depression. Basically, it can make any condition worsen or even just flare, from or uncover a condition that you didn't even know you had. How does it do that? Well, one of the ways we can understand it is looking at the main stress hormone, cortisol, and how many systems that it can affect. We know that it can, decrease, amino acid uptake by muscle. It can reduce bone formation, leading to weaker bones. It definitely interferes with the, sugar control. It can create insulin resistance. It increases ghrelin, which we'll talk about a little bit more. We'll touch on in the nutrition portion of this, but it definitely affects multiple systems. And so it's important to recognize when you do have stress. And so we're going to switch gears here and do a little bit of a poll. And we're going to put up several different types of symptoms. And I just want people to check off. You don't have to just pick one, pick as many as you want. But how does stress manifest for you? We'll give you a few minutes. Okay, are we getting close to there we go. All right, so these are some of the results. So a lot of people said irritability and frustration, yes. Fatigue, inability to focus, yes. Digestive issues, yes. Definitely. Okay. So we didn't get all of these in the poll because we were kind of limited, but these are 14 signs of chronic stress or anxiety. And it's important to just, take a moment, look over these, think about, are you feeling any of these now, or have you, in the recent past? Because recognizing when you are stressed and anxious is probably the most important step before actually building the stress resilience and being in touch with your body. And so once we know that we have kind of a level of anxiety or stress going on, what are some tools that we can use when we recognize these signs, symptoms, or behaviors? And that's what I really want to spend some time on. And a lot of these, there's nothing new, but I think that it's important to refocus and think about ways that we can implement simple techniques in our life to build the stress resilience. And first and foremost, let's start with mindfulness. I don't know how many of us relate more to the person than the dog. The dog definitely has it figured out. But the field of mind-body medicine has just been exploding, over the last few decades. And the more we learn, the more we realize how much our mental state affects our physical state. I think that we probably all take for granted that a worried mind can leave us more susceptible to ill health. But how many of us really buy into the fact that a positive state of mind can improve our health? And there are so many studies out there, it was hard to just pick a few. But this is just a couple of samples. This was a meta-analysis that looked at 34 articles relating to mindfulness practice in students. And what they found is that, yes, mindfulness-based practices, cognitive behavioral programs do definitely create, significant results in relation to reduction of stress, anxiety, and depression. And these were usually daily or multiple time per week type of interventions. This was a randomized controlled trial of mindfulness meditation for generalized anxiety disorder. So these were 93 individuals who had the diagnosis of generalized anxiety disorder. They were followed for 2 years, and they were assigned to either do mindfulness-based stress reduction or stress management education. And they used various scales. There are a lot of scales out there to kind of measure anxiety. There's the Clinical Global Impressions Severity of Illness, the Beck Anxiety Inventory. There's multiple ones out there, but they looked at 4 different scales, and in 3 out of the 4, the MBSR group actually had significant reduction in anxiety versus the control group. Also, they had greater reductions in anxiety and distress in response to a social stress test challenge, and they had a lot more positive self-statements. And so some simple mindfulness tools that I just wanted to remind you of. These are tools that can be used both in the moment when you are feeling particularly anxious or stressed, but they're also good tools to do when you're not feeling stressed, as building, I think of it as building that mindfulness muscle, just like you have to work out your physical muscles. We need to practice and build that mindfulness technique. The first one is, it's simple, it sounds so simple, but it really does help. It's when you're feeling anxious or irritable in the moment, it's just asking yourself the simple question, isn't it interesting that I'm feeling, and you fill in the blank. Isn't it interesting that I'm feeling anxious? Isn't it interesting that I'm feeling irritable? And what that does is it immediately takes you a step back from being the one experiencing the emotion to observing the one experiencing the emotion. And that's a lot about what mindfulness is about, is observation, being in the now. And this is I just want to point out, this is not an analysis. This is not, why am I feeling this way? I shouldn't be feeling this way. It's not judgmental. It's not analyzing it. It's simply an observation. Very simple, very powerful. Once you ask yourself that question, you can take it one step further and say, can I just be with being irritable in this moment? So isn't it interesting that I'm feeling irritable, and can I just be with that? Breathing exercises. I'm sure all of you have some type of your favorite breathing exercises, but I think it's important to to remind us that how powerful this can be. It's amazing to me, the autonomic system is there doing its thing, and this is a way that we can actually open the door and access it directly and support the parasympathetic, the rest and digest, and calm down that sympathetic fight or flight, right? One of the most common breathing exercises is focusing on the breath. That's a form of meditation. I think that's good to do daily when you're not necessarily feeling particularly anxious. In the moment, though, when you have a lot of energy or stress or anxiety, sometimes it can be difficult to do that. And for some people, it can actually create more anxiety. And so sometimes it takes a little bit more active breathing exercise in that moment. One of them is the timed 4-7-8 breathing, which is just inhaling for 4 counts, and you hold it at the top for 7, and then you exhale for 8. And then you immediately breathe in for 4, hold for 7, exhale for 8. Do that 4 times. One of my favorites, absolute favorites, and I do this a lot with my patients, is the alternate nostril breathing. And this is a yogic technique. So those of you who have done yoga have probably come across this before. But it's active enough that it keeps the brain engaged. And so this is the experiential part of the program. So we're going to do it together because I love doing it. We're going to sit comfortably. We're going to use our right hand. We're going to use the thumb and the ring finger. Don't ask me why it's the ring finger. I don't know. That's the way it is. And then we're going to start by just closing off the right nostril and breathe in through the left. And then close off the left and breathe out through the right. Stay there and breathe in. Switch and breathe out. Stay there and breathe in. Switch and breathe out. Keep going. I'm going to keep talking. So each time you switch, it's an out breath and an in breath, and then switch. If you feel like one side is very plugged up, you can sort of cheat and sort of halfway cover the other nostril so that you're not, feeling like you're suffocating. You can also close your throat a little bit to slow down the breath, and that helps make kind of a Darth Vader sound. And then when you're ready, you can just end with an exhale. All right. And then, of course, guided meditation is wonderful. And there are apps, there are a lot of apps out there. I love free apps. And Insight Timer is one that has literally thousands of guided meditations, music. There's a lot of ones focused on sleep if you have trouble sleeping. Simple Habit also has a lot that are free. And both of those you can subscribe and get access to more things. But the free version is pretty good on its own. And if you, there are ones that are just like 5 minutes long. And if you just have a few minutes and you have it on your phone, you can just do a quick guided meditation. All right, moving on to nutrition. So we all know eating healthy is going to help with our physical and emotional health. The studies also back that up. I mean, zinc, magnesium, vitamin C, the B vitamins, the omega-3 fatty acids, they've all been shown in studies to help reduce general anxiety. Vitamin C and pantothenic acid are essential for the adrenal glands. The adrenal glands are your stress organ, and it's what produces the cortisol. And so adding plenty of fresh leafy greens, nuts and seeds, salmon, omega-3 fatty fish are all going to provide you with some of these essential nutrients. If there's one food to eliminate to help build stress resilience, it would be sugar. And this is so hard because when we're stressed, we want to eat sugar. We want to grab for that cookie, right? And that goes back to that cartoon of cortisol, that the reason is because it does increase ghrelin, and ghrelin is your hunger hormone, or one of them anyway. And so when we're hungry, we're hardwired to just reach for anything that's going to, raise our blood sugar very quickly. But again, this is a double whammy, because cortisol is also counteracting the effects of insulin, creating insulin resistance. And so the next time you feel like reaching for that cookie, just remember this cartoon and just kind of play it forward. And sometimes that helps. I know it's hard. Healthy movement. So we're not talking about 30, 45 minutes, 60-minute exercises. I know that there are probably some of you out there who feel that if you can't exercise for at least 30 minutes, what's the point, right? And I challenge you to reframe your thinking about that. Think of it as a mental, emotional tool rather than, a physical trying to train for a triathlon kind of tool, right? Yoga, there's so many studies about yoga that have been shown to, improve the autonomic function, make changes in the neurochemistry, reduce anxiety, help with sleep. But if yoga is not your thing, that's okay. Any kind of movement is going to be beneficial. Just set the timer on the phone to go off every 60 minutes or so. 5 minutes, stretch, take a short walk, do some push-ups, do some lunges. There was a study that showed just 5 minutes of movement every hour created greater happiness, less fatigue, and considerably less craving for food. So if you're having that sugar craving, take a 5-minute break and do some physical exercise that that resonates with you, and it can help with that food craving. Healthy sleep habits. We all know that this is important. We're all very aware of good sleep hygiene, getting to bed at a regular time every night, no late night eating, or caffeine or alcohol. All of those will disrupt the sleep. But starting to wind down earlier in the evening. So starting to dim lights, get away from the screens, maybe around 9 p.m. In Ayurvedic medicine, they feel that that the prime sleeping time is around 10 p.m. to 2 a.m. And so trying to get that good quality of sleep is important. For people who have trouble going to sleep because the thoughts are just going around and around, or those who wake up and start thinking and can't go back to sleep, keep a notebook by your bed with a pen and just dump it, just scribble it. Don't even have to turn on the light, just scribble it down, leave it there. If none of that works, then you can try a small amount of melatonin, which is a hormone made endogenously, but we can also take it. I would start with a very small amount though, because people respond very differently to melatonin. We used to just throw around 3 milligrams as the standard, but more research has shown that sometimes less is more, or less is more effective. And so I would just start with very small amount, 0.5 milligrams. Sometimes you can get these liquid ones and you can titrate it appropriately. If you keep it by your bed and you wake up at midnight, you can even just use a little bit of a drop to help get back to sleep. There are some herbal supplements. There's herbs that are known as adaptogens. Think of it as agents that help support the body's ability to accommodate, varying physical and emotional stresses. They also support the hypothalamic pituitary adrenal axis. And there are a lot of different adaptogenic herbs out there, but two of my favorites are holy basil, also known as tulsi, and ashwagandha. Holy basil is used a lot in Ayurvedic medicine. It's had in both animal and human studies, it has been shown to increase endurance and help reduce anxiety, insomnia, and memory issues. Ashwagandha is used both in Ayurvedic and Chinese medicine quite a bit. There was a recent double-blind placebo-controlled study that suggested that ashwagandha root extract safely and effectively improved an individual's resistance towards stress and also his or her self-assessed quality of life. Lavella lavender oil capsules. This is one that I use quite a bit with my patients. There was a study that was a multi-center, double-blind, randomized study. They compared lavender oil preparation, this particular one, to lorazepam for people with generalized anxiety disorder, and found it to be as effective as lorazepam. In general, in my practice, I find, of course, nothing works 100% of the time for 100% of the people, but I find that for a good majority of people, they notice just a little bit of just a little bit more calmness, feeling like when stressors occur, they're able to manage it just a little bit better. Any of these herbs, though, I don't recommend in pregnancy. If you're breastfeeding, talk to your OB-GYN. But in general, we tend to be pretty conservative when it comes to pregnancy and breastfeeding. So many other modalities. So acupuncture, one of my favorites. I think that it's thought most oftenly with chronic pain, but I find that it's incredible for both sleep and anxiety. Therapy, of course, is going to be beneficial, and there are many different types out there. Massage can be a nice break, give you some time to just meditate while you're getting some body work done. And then the rubber ducky, I don't know if anybody's going to know, guess what I'm thinking on that one, but this is hydrotherapy. Hydrotherapy is a modality that's been used for a very long time in naturopathic medicine, and there are different types. There are foot baths, and there are constitutional hydrotherapy. There's a lot of different types, but the main thinking behind it is a hot and cold kind of therapy. And so getting the vessels dilated and then contracting and dilating and contracting, gets more blood supply, clears out the toxins, increases the cell metabolism. But this is something you can do very easily in your shower. After 3 minutes of warm, do 1 minute of cool. You can do it up to 3 cycles if you want, but even one could be beneficial. It just wakes you up, makes you feel a little bit more ready for the day, and I think can build stress resilience over time. HeartMath, heart rate variability. So this has become more well known, especially with like the Oura Ring and things like that are looking at the heart rate variability. But the idea is that your heart rate is changing with your breath and with your breathing, but ideally you have a nice sinusoidal pattern. But when you're stressed, when you're feeling irritability or frustration, it could look more like the jaggedy pattern on the left. And so this is biofeedback, and it's a device. So heartmath.com is where you get this, and it's about a $200, I think, device, plugs into your phone, and you're just breathing until you start to see the nice sinusoidal pattern. There have been a lot of different studies on this that have shown that it helps with anxiety, it helps with stress, it helps with insomnia. I think it's a really good technique to use. It's one of the few that is not free, however, but I did want to mention this study where they looked at 40 physicians actually, and they were divided into either a group using this device 3 times a day, or the control group, and then both groups actually had a twice weekly support visit from the research team. So they looked at the results after 28 days, and then they stopped and looked at, like 56 days out. And what they found is that the physicians that were doing the heart math, their mean stress score declined significantly as compared to the control group. The stress score was based on some various self-assessed levels of stress and anxiety, but what they did find also is that it was maintained 56 days after the initial start of the study as well. So, wrapping up, stressors are part of life, and I don't think there is such a thing as stress reduction, but we can try to build resilience to it. We can try to find more balance. And although that, stress can have benefits, chronic stress is obviously associated with a lot of chronic disease and ill health. And so the more things we can do to build that resilience, the better off we'll be. And there are many, many tools and levers available to us to do that. The question is, where do you start, right? And sometimes it can seem overwhelming when there are too many choices, but I encourage you to just start by incorporating one small change. There's a book called Atomic Habits by James Clear, who he talks about how to incorporate very simple changes into your life, doing things like piggybacking it onto a daily habit, for instance, and how these small changes can make a dramatic difference over time. And so just remember that a journey of 1,000 miles begins with a single step. And so we can turn it over to questions and discussion, but one thing I wanted to ask all of you is, what do you find most effective in helping to build stress resilience? Yes, tiny habits, yes. Somebody mentioned tiny habits. So atomic habits and tiny habits. I don't know who came up with the idea first, but they're very similar, and they're both very good books. Yeah. Exercise, yes. Deep breathing, yoga, absolutely. Morning yoga practice. I find the same. Yoga is fantastic. Coffee. Walking in nature, yep. Swimming, acupuncture. I love acupuncture. Boxing, yes. Sunshine, somatic work, dog, yeah. Massage. Oxytocin nasal spray. Aerobic dance, laughter. Laughter is wonderful. Good healthy meal. My bearded dragon. Sex, okay. Someone had to say it, yeah. Easy to digest meals, yes. Hot packs, I like that. Pranayama. Absolutely. Cold plunge.
So Wendy, while those are coming in, could we go on to some questions?
Yes.
Oh, okay, perfect. And thank you so much for just a wonderful presentation. You're such an important topic, and we're getting a lot of such positive feedback in the comments. So thank you for that. Okay, so question about let's see, dosage of lavender oil that is helpful for anxiety. Is there a specific dosage that you would recommend, or how do you typically use lavender oil?
Yeah, so I generally use that brand Lavella just because I trust the brand Integrative Therapeutics, and that was the product used in the study. And so it's just 1 capsule a day, usually with a full glass of water.
Okay, perfect. This question is, if there is enough REM and deep sleep, does it matter how many hours a person sleeps and the time one goes to sleep?
That's a good question. I wonder that myself sometimes. I do know that, there in Ayurvedic, both Ayurvedic and Chinese medicine, time of the clock, our circadian rhythm, the time of the clock is very tightly linked to our, either meridians or chakras. And so from those perspectives anyway, it is thought that, going to bed around 10 o'clock or being in bed, by 10 o'clock is important. Now, I know that there are some people who say, I've never been able to do that. I can't do that. And for them, it's just do the best you can. Sometimes it's a matter of just very, very, very gradually moving that bedtime, more closely. And I think too, it's hard to measure the amount of REM sleep. I know these, like the Oura Ring and the Apple Watch try to measure the quality of the sleep, but I don't know that it's been shown to be super accurate yet.
Okay, perfect. So question about how you would tailor mindfulness or meditation to different cortisol patterns. So if a person has a cortisol upswing in the morning, would you recommend meditation in the morning versus cortisol downslope where they might benefit from meditation in the evening? Do you have any thoughts on that?
Yeah, so I think it's more a matter of just getting it in when you can get it in is number one, most important. So, trying to time it, that's more nuanced, it's whenever you're going to do it, right? I think that we all have or we all hopefully have the upswing of cortisol in the morning. It's usually when we first wake up. It's at a certain level, and then an hour or so later, it comes up, which is okay. That's what it's supposed to do. I don't feel that meditating during that time is necessarily going to, how should I say, disrupt your cortisol patterns or rhythms.
Okay, makes sense. And any concerns about supplementing melatonin in terms of inhibiting your natural melatonin?
I recommend not using it consistently day after day after day. There are some people who, after a time, can start to have things like morning headaches, mood changes in the morning. The best evidence is really for just short-term, like jet lag kind of conditions. So, and I don't know if it actually disrupts. I don't know if the studies are out there to show whether it actually disrupts your own endogenous production of it. But it's something, sometimes some of these systems just need a little bit of a kickstart for things to start to work right. And if you're not sleeping, and if the melatonin gets you sleeping, then things might start, falling into place.
Makes sense. Well, in the interest of time, unfortunately, we have to stop with the questions. But thank you so much, Dr. Reeve, for giving us this talk and speaking about this such an important topic.
Thank you.
Okay, great. So now I'd like to welcome Dave Asprey. So thank you for joining us, Dave. We're delighted to have you. Let me go ahead and properly introduce you. So Dave Asprey is the founder and chairman of Bulletproof Incorporated. He's a 4-time New York Times bestselling science author, host of a top 100 podcast called Bulletproof Radio, and he has been featured on the Today Show, CNN, the New York Times, and more. So over the last 2 decades, Dave, the so-called father of biohacking, has worked with doctors, researchers, and scientists to uncover the most innovative methods and products for enhancing mental and physical performance. He's the creator of the Bulletproof Diet and innovator of Bulletproof Coffee and collagen protein supplements. And Dave's mission is to empower the entire globe with information. So through the Bulletproof Diet, Dave has maintained a 100-pound weight loss, improved his sleep, and upgraded his brain, ultimately transforming himself into a better entrepreneur, better husband, and better father. Dave has helped hundreds of thousands of people perform at levels far beyond what they would expect and without burning out or getting sick. So in addition to hosting Bulletproof Radio, a global top 100 podcast, Dave is currently serving as the founder or chairman of 6 health, wellness, and biohacking companies. Please join me in welcoming Dave Asprey.
Thanks, Dr. Palasami. And Dr. Reeve, that was a great presentation. I really appreciate it. And I also want to give a shout out to Rob Wolf with his conversation about sodium. There's been a few.
Oh, actually, sorry, Rob was, he had a family emergency. He couldn't do that one today. Yeah, so I had to fill in for him, but he's going to do it for us later on.
Well, I clearly wasn't on earlier. I'm actually in Las Vegas with my 12-year-old doing a father-son trip and took some time out for this, but I want to add that to the list of things that are rejuvenating, which is having fun and doing things that 12-year-olds like to do.
Yes.
As a little asterisk to our last presentation. And you asked me to speak, and thank you. I'm always honored when I get to speak to real doctors because I am an unlicensed biohacker, which means you can't take my license for saying things that might be difficult to say even if they're true. And I do my best to be fair and balanced when I say things with that little asterisk that I'm not a medical professional, but I know a thing or two about mitochondria. So thank you for the honor of your attention. A practical approach to quantified self is a kind of a challenging topic and a little bit of a boring topic. And I decided not to have slides because I think you probably might be slided out. And I'm going to share some real practical things that have to do with helping patients do this. And by way of background, I used to weigh 300 pounds, and I had most of the diseases of aging before I was 30. Lab tests showed high risk of stroke and heart attack, very, very high levels of thrombin and fibrinogen. I was pre-diabetic, which basically is the same as diabetic. At least if you ask me today, I would say that's the definition of it. I had arthritis in my knee since I was 14, and I had serious cognitive dysfunction, fibromyalgia, chronic fatigue, and a bunch of other stuff that I don't have now, which is remarkable. And I've spent more than $1 million first healing that, and I shouldn't have because I didn't know how to find doctors like a lot of the people attending this. And also, I'm very fortunate to have been able to do that, and a lot of that now is kind of hitting new levels of things I didn't think I could do. My current true age, methylation diagnostic age, shows that I'm 11.25 years younger biologically than I am chronologically. So I like to think it's working. But how the heck do you do quantified self? If you go back about 11 years ago, when I first spoke at Quantified Self, and a little point in history, I got the HeartMath Institute to come and become a part of Quantified Self to make heart rate variability, which Wendy just talked about, to make them a part of the movement. Because what the Quantified Self movement really is about is gathering historical data, thinking about it, and then deciding to change. Now, if you work with patients, I think you understand, and Dr. Reeve mentioned a little bit about tiny habits or atomic habits. It's actually not knowing what to do. We all know we should exercise, we should go to bed earlier, but it actually isn't a very good motivator for behavior change. So the Quantified Self movement kind of stalled out a little bit because there's wisdom we can gain by looking at our data, but doing something with the wisdom is not what Quantified Self was ever about. It was about illuminating things. Biohacking, which became a word in the English language, and my name is in Merriam-Webster's there as creator of it, it was about taking action. And what a scientist, an academic, or even a physician is likely to do is to make the unproven and unstated assumption that it's just one thing causing something. So we look for the one drug, we look for the one cause. But when you're dealing with foundational or systemic issues like mitochondrial dysfunction, autoimmunity, or mast cell activation, it's not a single system that's affected. And I learned this the most by working with my own experiences with toxic mold and then eventually doing a documentary about it. If you deal with toxic mold in patients, completely free, moldymovie.com is a documentary where there's a dozen doctors saying it's real and a dozen patients who were just taken out and then recovered. And that was sort of my giving back thing because it's such an interesting situation that you can have two people. In fact, my favorite example from this, which relates to Quantified Self, is the husband and wife couple. They're both MDs. They live in a moldy trailer because they were remodeling their house. And she got profoundly ill and he didn't have any symptoms. So she thought, as her medical training said, that she must be a hypochondriac because she had 12 symptoms. And everyone in medical school knows if you have 12 symptoms, you're probably a little bit crazy. But her body temperature was elevated by 1 degree, so she knew she wasn't crazy. So she did what any good doctor would do. She biopsied every organ in her body, probably except one, and couldn't find anything, and eventually figured out it was mold. And on the video, her husband's sitting there saying, look, we're both doctors. I don't feel this, but I know it's real and it's affecting her. But the symptoms were so varied and all over the place. But how would you apply a quantified self to that? Well, it turns out that I'm a huge fan of a principle that's in one of my books in Game Changers called track what you have. So you tell your patients, look, you could order all kinds of labs for you. We could spend $10,000 on labs, but what are the ones that are actionable and highest on your list of things that you care about? If you have that, then you say, all right, let's look at the things that are likely to contribute. And what a typical medical approach to do is say, well, let's try one therapy at a time. What a typical biohacking approach is to say, what are the markers I want to move? And if so, I'm going to do everything that moves markers, because I'm not a number and I'm not a statistic. I'm actually a person. And what I care about is getting my life back. And I can say that thinking that my life was not very good when I had all those conditions. I was in a lot of pain, and frankly, it's miserable. So there's a sense of desperation there. And that means I'm probably wasting money, and I might be doing things that don't work. And what you do is you get the result, and then you start backing off on things until it stops working. And that's just a much more efficient way than trialing every single vitamin on earth to see which one's going to work, because you can do that for a month, and by the time you're dead, you wouldn't have tried all the vitamins available today, not to mention pharmaceutical drugs and other therapies. So the first thing that I would say as a principle for this is you're going to have things that are broad spectrum indicators of what works. The number one most effective and broad spectrum indicator that it's working right is your heart rate variability. Now there's the heart math device, which is good for training heart rate variability. And I'm certified as a coach, at least I was a while ago, with heart math. So that's profound for teaching autonomic nervous system control. But from a more of a quantified self, let's measure this and get some information that we can use later. It turns out your nighttime heart rate variability is profoundly useful. I use the Oura Ring. A disclosure, I am an early investor and advisor in the company. And what the Oura Ring does, and a few other trackers like Whoop will do this, they'll give you a resilience score, which is primarily heart rate variability plus body temperature, plus the time that your heart rate reaches its lowest, which you want to be earlier in the day. If you combine those with the percentage of deep sleep and REM sleep, what you get is a really good indication that something you did the day or 2 days before, maybe even 4 days, but usually it's 1 or 2 days before, made a big difference in your sleep. So when you have a patient, you say, okay, I want you to do all these interventions, but you know you're only going to do 2. Well, let's get this ring on you. And if the 2 you're doing are working, that's fantastic, right? And that's going to tell you even blood sugar regulation. It's going to tell you likely whether your hormones are improving, whether your testosterone's going up, your hormones going up, and you can match all those labs, but people don't necessarily want to draw blood all the time. So you're saying, look, if what you're eating works, then you should see a change. If you think eating at 8 o'clock at night after the sun goes down is good for you, see what happens. And what patients will do is they'll come back and say, oh, you're right. If I eat at 5:30 before the sun goes down, I get my deep sleep. And if I don't, I sleep the same amount, but I don't. So suddenly you can get feedback within a 24-hour cycle. The most important thing that you can do within the quantified self versus biohacking realm is have closer to real-time feedback. Another example of that is this little guy. This is a Levels Health device. It's a Libre, which you can prescribe if you're an MD, but I get it from Levels Health. It's a continuous glucose monitor. If you have diabetic or just overweight people, there's nothing like saying, you know, let's see what happens an hour or 2 after that meal. And strangely, the real-time feedback means I didn't have to think about what happened over the week, make a decision to eat less French fries. It means when I sit down to eat the French fries, like, oh man, I'm going to have to see this right away. So the tighter the feedback loop, the better it becomes. And suddenly you say, no, I'm not having dessert. No, it's not worth it. Or if I'm going to have dessert, I'm going to do 25 air squats because I know instead of going up to 145, my blood glucose will go to 130, and I'm okay with that. Oh, and I'm going to take some cinnamon and some chromium and some vanadium and maybe some carnosine to protect myself from the glycation that happens from the blood sugar spike. Depends on how much of a nerd, how much of a biohacker, and how long they want to live. But having the data in real time is just precious. And if that was my one piece of advice that you could take away, is get them on Aura or a similar device. If they're not going to make that kind of an investment, there's a company called Sleep Space that's spent more than $1 million of NIH funding. Dr. Daniel Gardner is familiar. I'm also an advisor and investor, so I'm doing my best to disclose these things. I know a lot about these, so I can talk about them. Where he's got the most clinically validated algorithms to get very close to a hospital-grade sleep study by interpreting data from other devices or just using sound in the room. So I recommend that to the people who follow me on social media and to members of groups. And that's the very affordable thing. But whatever it is, these applications on the phone that include an alarm clock, most of them now have an alarm clock that has progressive waking. This isn't technically quantified self. It just lowers stress for most people, especially the devices that will detect how you're doing. And they're going to say, okay, you're in the middle of a dream. We can wait 10 minutes to wake you as long as you have a waking window. It makes a huge difference in the quality of your day. If you're jarred out of your sleep very, very deep in a dream or even in deep sleep, which is less common later in the sleep cycle, you're just going to have a bad day. And you might be able to recapture this by having more salt in the morning, maybe having coffee to get your cortisol spike in the morning where it belongs instead of in the afternoon. It doesn't, given that it's a circadian problem. So I look at that as something where almost anyone can benefit by seeing the quality in their sleep and then their blood sugar. So those are the two lowest hanging things.
Oh, sorry to interrupt, Dave. Can I interrupt you for a second? Some people have a little hard trouble hearing you. Maybe your microphone, if you move it up a little bit closer to you. Some people have said their audio is cutting in and out a little bit. So yeah, that's.
Is this better? If it doesn't, I'll switch to the computer mic. This is usually really good.
I think this is sounding better. Great. Thank you.
Okay.
Perfect.
Thank you for letting me know, guys.
Absolutely.
I appreciate that.
Thanks. Okay. Perfect.
Okay. Oh no, if you can't hear a third of what I'm saying, it actually turns out that you can train your hearing to be better. That's just my bad sense of humor. I wonder what you guys missed. This is better. If it happens again, let me know and I'll switch mics together. This is one I use for portable podcasts, so I figure it should be good.
Great.
The idea that we've got blood sugar, we've got sleep, especially heart rate variability, that makes a huge difference for patients, and that you can use things like Sleep Space, which is an app based on the phone, and that those work really well. But let's be practical about this, which is what you asked me to do. It turns out the number one problem with quantified self is what I call friction. And that's how hard is it to track it? Well, if you reduce friction and you make it really simple, then people will actually do it. So if you want to know what really works, you use the app that is your alarm clock. And most of them have the ability to take notes. And you can actually define interventions that you tested. So for, 7 years, I had a list of 30 or 40 things I was testing. And every day I did those, I would check the box that said what I was doing. So at bedtime, as I'm setting the alarm, it's very simple to go check, check, check. Yes, I did my red light therapy. Yes, I wore my glasses that block more than just blue, because blue blockers actually don't help reset your circadian rhythm. They just raise melatonin. There's better ways to do that by blocking other spectrums of light and the angle of the light and the intensity of the light. Those are all variables that you've got to control. And what you end up with if you do that is, oh, I took my vitamin C today. I didn't take it today. And eventually you can see, oh, this is correlated with that. And the apps do that by themselves now, where you can very quickly say, I just got the best night's sleep ever. What did I do yesterday that worked? And it's that idea that it wasn't hard. I had to set my alarm anyway, so it just took 10 seconds to do it. The kind of personality that's obsessive and says, I'm going to record all of my data about everything, it's kind of like being a stamp collector or coin collector. You're not going to actually spend the coins or send mail with the stamps. You just kind of like it. And there's actually personality tests that will define how much data you need to make a decision. So these are what I would call data hoarders. And it's not necessarily useful data. And at that Quantified Self meetup in 2011, I met a couple, we're so excited. We've got 10 years of her menstruation and fertility data. And I said, that's awesome, because this was very hard to do 10 years ago. What are you going to do with all the data? And they looked at me like, why would we do anything with it? We just got the data. Isn't that cool? And there is that kind of a mindset, but those are the people who are going to be, and I'm making up a word for you right now, they're going to be data-rexic. So we all probably have heard of orthorexia, which is people who are fearful of not eating the right thing. So pretty much they just have stress around food altogether. And that isn't something that we want to induce. There is something else happening now that I've seen, and I call it PTSD, post-traumatic sleep disorder, where people who are using sleep trackers are now afraid of not getting enough sleep. So the stress about not sleeping keeps them from sleeping. This is a real problem, and it's a downside of quantified self. So you want people to feel empowered to change the numbers, but not like they failed if they didn't achieve the change they wanted. What I do like to say when I'm sharing this with my mentorship group is I'll say, look, if you had a bad night's sleep, it's your fault. If something's going wrong, it's your fault entirely. That means you can change it and you can improve it. Because if it's not your fault, it's just God or the environment, something that you have no control over, you're just a helpless victim. And I'm not about that. It's about actually empowering patients. So when a patient leaves a room excited that they're going to get a score and they're going to be able to figure it out. Chase, you were asking the name of the CGM I use. I use one from Levels. Go to levels.link/Dave, and they put you to the front of the line. I don't get paid on that. But if for physicians, it's the Libre system. I think it's, I forget who makes it, LIBRE is that's actually the sensor that they use within their app. Just their app is better than Freestyle. And I got myself distracted there. But what you're looking at with patients is making sure that they're not worried about getting a bad score. Most of that fear actually comes from high school and missing exams and pressure from parents and things like that. So they say, oh no, I failed in my sleep, and it doesn't work. So if you can teach your patients, this guy is crazy, yes. If you can teach your patients to, thank you, LSH, is the freestyle that helps with us. If you can teach your patients to actually be calm about this, you will find that ones who have the worst sleep are terrified of not getting good sleep. It's a thing. You'll also find that some of the quantified self people who you may find in your practice, especially if you're a functional medicine doctor, are overwhelmed with data because they have to have the data or they don't feel safe. And honestly, those people need therapy. And it's okay to tell them that because they're anxious people. Or there are people like me who have been so profoundly affected by toxic mold, environmental toxins, systemic inflammation, infections like Lyme disease, that they're actually worried. I bought disability insurance when I was 26 years old because I didn't know if I would hire myself because my brain was. I was also profoundly successful in my career and I was fighting it really well, but I was right on the edge. So you can have patients who are just wrecked, or you can have patients who are fearful. You need to figure out which one it is when you're dealing with the quantified self kind of thing. I'm going to switch mics and see if this is better. Give me a second, guys.
All right. Now, what we're talking about here is I don't know, for everything I'm doing in my lifestyle, we're looking at your heart rate variability score in the morning. And for encouraging people to eat stuff right, real-time feedback from continuous glucose monitor. You can ask patients to track things with a food diary. I find it doesn't work particularly well. Most people won't do it. If they snap a picture, it doesn't work. Calorie tracking is exceptionally useless. The reason is that calories are a fantasy. As a guy who started a major food manufacturing company, it's very hard to tell you there's 100 calories in a bar because cashews have more or less calories in them based on how much sun they got and what kind of soil they were grown in. And it's a fantasy to say that you're weighed your food, see how many calories are in it, because the hydration in the food is the biggest thing, especially for vegetables. So what is much better from what I've experienced, and I've helped people lose at least 1 million pounds, is looking at how you feel a half hour and an hour and 2 hours after a meal. And if you're hungry, you have cravings, or you have blood sugar dips, that is a much better indicator than, oh, I must have eaten too many or too few calories. What I did that was profoundly useful was, and this works for patients who have problems with their energy, is just tracking, even on a notepad, even on your iPhone. I noticed I felt really good right now, or I noticed that I was feeling really foggy right now. And just taking a little second to write it down, then you go, oh, what caused that? So it's the awareness. In fact, some people in the space are now calling this meta awareness, which is having a little process running in your brain that says, how am I feeling right now? The quantified self angle on that is writing it down. And what people will find, and if they share the data with you, what you'll see is that there's a pattern to it. It's a time of day. So then you look back, oh, how's your HPA doing? Maybe that's what it is. Do you have low cortisol, which is a very substantial problem, way more so than most people recognize. And low cortisol is oftentimes tied to mast cell disorders. Now, there was a recent very popular virus that shall not be named, and it appears that it increased people's mast cell sensitivity pretty severely. So some of the people with the long form of what I'm talking about seem to respond really well to things that stabilize mast cells. But one of the side effects of that is low blood pressure. So when we're getting into the higher end quantified self devices, Withings and Omicron make portable blood pressure cuffs. The Withings one goes up here. The Omicron one is on the wrist, as you guys know. The ones that go up on your arm tend to work better. But they're reasonably accurate, even compared to what you would do in a clinic. They're about the same. So getting blood pressure from people who are having a hard time is really useful. Yes, high blood pressure is an issue. And that's one where if people can track that, it works really well. But that's more quantified self. What if we put on our real-time feedback biohacking lens? Now, you guys have all seen fighter pilots where they wear those pressure pants, suits that lace up so that they don't pass out when they're doing high G maneuvers. Well, the other thing that they're trained to do is when they're going to lose blood pressures, they squeeze the flight stick really hard. There is a company that actually will allow you to, and this, I don't have any relationship with these guys, it's called Zona Health. It's a biofeedback device that takes 8 minutes a day where you squeeze, not too hard, not too soft, enough to train your body to regulate your blood pressure. And they have an 80% plus success rate and dozens and dozens and dozens of papers over the last 15 years, mostly published in Europe, not in the US, because it's harder to make claims here. It's a quantified self biofeedback device to train your body to have more awareness and control of your blood pressure regulation system inside your arteries. So you start with the, oh, do you have high blood pressure? You should be aware of that. Let's track it on a daily basis. What's making you tweak? And then from there, what are you going to do about it? Maybe you should try magnesium, make sure you have enough potassium, right? Look at all the other things that you would do as physicians. But then maybe you also say, why don't we add some more real-time awareness? And as you go from gathering data to get knowledge to training the automated systems in the body to do what they're supposed to do better, suddenly a whole world opens up, both of technology and interventions. One of those is that. The other one that deserves mention is neurofeedback. There are a variety of devices you can get now that will train. Yes, that was Zona Health, Mary Jo. There's a variety of devices that will actually allow you to train your brain. Like Muse is a very basic EEG system that's getting a signal from the front of the brain. I have about 8 years of deep experience with this because my 40 Years of Zen program has had 1,200 people do 5 days of intense neurofeedback with QEEG as well as some in-house stuff. And what you'll find from this kind of stuff is that you can have profound changes in the way the brain works. And I don't diagnose or treat anything, but there's hundreds of studies for almost anything you could think of, especially depression, anxiety, and things like that. So you start realizing, okay, if a person becomes aware that they have anxiety, and people who are always anxious don't necessarily even know they have anxiety until they realize it's abnormal. Raising my hand here as having been one of those. What happens after that is you can start working with heart rate variability as a feedback system actually on the ear, but then you start going into my heart rate variability at night. That wasn't about training, that was about awareness. And then the next step from heart rate variability may be just breath training. And you can do that with a capnometer. There's a couple of companies that make those. So you can just track your breath rate. And from there, you can go into a basic level EEG, or you can do clinical grade EEGs where you glue electrodes in multiple parts of the head. I've seen much more effectiveness of that. But what all of these are doing is bringing awareness to systems in the body that you didn't know about. They're all quantified. You can score all of them, and it works shockingly well. Another form of quantified self is VO2 max. Most people don't like doing VO2 max training, but for someone who's interested in more athletic performance, VO2 max is both a good indicator of performance as well as longevity. And it turns out there are interventions you can do along the way that look at things like heart rate and intensity rate of exercise with AI algorithms. And that's a big part of what I'm doing with Upgrade Labs, which is a franchise where people can come in and get quantification and then make interventions based on the quantifications we get. One of the biggest quantifications that I'm doing there is actually cell phase angle. And I'm guessing a lot of people in attendance may not have heard of this, but it's one of the most underrated ways of looking at cell biological performance. Now, you could say, how are my people ever going to get this? Well, they're going to have to come to your office or go to a facility like Upgrade Labs that has one. But these are about a $26,000 system and up from there, from what I've seen. And I'm blanking on the name of the company that does that, or I would tell you guys. I'm seeing the scale, but I can't think of their name. So what this does, it runs a very small amount of electrical current through the body. And there's two things your cells should be able to do. At one set of frequencies, your cells should be able to store electricity like a capacitor and then forward them. And the other one at a different frequency is that your cells should be able to provide electrical resistance to a current. And the ratio of those two forms a score called cell phase angle. And if you want to know, do you have healthy cells or not, it's going to tell you that. And more interestingly, it changes over time with intervention. So you can see a change over the course of a day or two, but it's relatively stable. There isn't a number that's the right number for any one person. It varies based on gender, and it just varies based on who you are. But when someone does something right and they see a positive shift and they go, aha, it worked, and they do something wrong and they see it go down, this is a kind of a lagging indicator, kind of like HbA1c is for how many carbs you've had over the last couple of months. So I look at that as a really effective way to say, how am I doing? And then there's 3 lab tests that I think just almost have to be done. One of them is C-reactive protein. It's a baseline, and maybe we're getting into medicine versus quantified self, but if the sum of all the stuff you're doing isn't getting rid of your inflammation, you kind of have a problem there. So then you should look at systemic infections, teeth issues, and things like that. And the second thing would be homocysteine, because there are a lot of people out there who have MTHFR issues, and if you have low homocysteine and low CRP, well, you're probably going to live a lot longer than most people. And the third one would be Lp(PLA2). And this one, some people are less familiar with. If you're looking at the sum total of whether all of these cholesterol markers or triglycerides or anything else are causing damage to the glycocalyx, the lining of your arteries, well, either there's an enzyme released from damaged arteries or there's not an enzyme released. The cause of that can be debated and can be tweaked and be hacked. But if Lp(PLA2) is low, C-reactive protein is low, and homocysteine is low, what you're doing is probably working really, really well. Monica, you didn't find hsCRP sensitive to inflammation, but you can with obesity. That's interesting. Brittany, does cell phase angle correlate to senescence? There are no studies about senescence, but the odds are very, very high that senescent cells, or so-called zombie cells, would be unable to store or repel electricity. So I'm pretty sure it would, but I don't think I've seen a specific study. The third test was Lp(PLA2). I told you guys, remember, I'm not a doctor. I just had to deal with all this crap for myself. And I go deep and then I write books about it. And I'm kind of an event correlation machine. So this is why I'm kind of veering onto the medical side, because for this audience, I think that's appropriate to do. Monica likes homocysteine as well. And there are, of course, things like the ratio of HDL and triglycerides and things like that. But generally speaking, when you're dealing with a patient, unless they're a super nerd like me, they can kind of get overwhelmed. So I like to highlight a couple things. I'm talking to a friend who says, hey, what do you think about this? I say, A, you should talk to your doctor. They're your care provider. But B, here's the questions you might want to ask, right? And it's usually when you have the weird cases where I have really high HDL, but my total is kind of high, but my ratio is good. What do I do? Well, it depends on the philosophy of your care provider. But if someone comes in and all of those are wrecked, then you have a lot of work to do. And that's a really effective thing. And maybe the right work to do is to say, why don't we get you a CGM? Why don't we get you a sleep monitor? And we're going to start with those. And then maybe that's going to encourage you to not have a drink of alcohol every night. Because even though the wine industry paid for a study that said it was good for you, the Alzheimer's doctors and then the other doctors are now to the point that it doesn't work. And if you track your sleep, one drink of alcohol at night will almost always disrupt your sleep quality, even if you get the same amount of sleep. Even if you fall asleep faster, it actually isn't good for sleep. People just don't know these things. You can tell it to them, but if they wake up in the morning and they got an F on their sleep, they get that sense of frustration that says, I got to do better next time. And it's that sense of frustration that makes quantified self, especially closer to real-time quantified self, more biohacking. It makes it such a valuable thing for creating change in people. And if you add the hints from Tiny Habits, where when they get a good score, whether it's on their CGM or it's they just decided not to add sugar to their coffee, this sounds really stupid, but it works. My wife's a medical doctor. She does it. You say, yes, and you do it like 10 times. And for some reason, the yes, it cements it in your body as a little celebration. And then the habit just becomes automatic because there's a part of your operating system that loves hearing that. So that's how you create patient change if your patients don't think you're crazy for telling them to celebrate that they didn't eat the French fries, but it actually does work. And then they'll see the change in all the different scores. And again, just to kind of repeat myself, if you have someone who's completely new who walks in and asks you what to do, I would say, number one, sleep tracking, whether it's a free app or the Ring. Number two, for creating patient health, is probably continuous glucose monitoring right now. And you're also going to see the people who are high anxiety and high stress, but it's more internal stress versus the fact they're just in a really crappy job or something. The people with high internal anxiety, that's probably a neurofeedback or the HeartMath Institute clip-on. Because the HeartMath Institute will train you to notice and then turn off internal anxiety. And neurofeedback, even something as simple as the Muse, is going to teach you how to reach a state you didn't know how to do. Totally outside the realm of quantified self is the realm of psychedelic medicine. I'm not going to go into that in this talk because that's not the goal for it. For those type of people, within the medical system today, I've seen incredible results from ketamine therapy that is approved now, I believe, for depression. It takes a few sessions. It is legal in all 50 states and doesn't require a lot of things that would be illegal or just not as well tested. So I'm a big fan of that for high anxiety people because all of their quantified self scores get better if they turn off the internal anxiety. It's a real important thing. I feel, is it time? Oh, for sleep, Monica, or a Ring, I love it. Whoop is really good. And for people who just aren't going to make that kind of investment or aren't going to wear it, what I would recommend is Sleep Space, which is an app that's run by a PhD sleep researcher, Dr. Dan Gartenberg. It's called Sleep Space, and it's got a very good tracking, whether it just uses the microphone or it actually has an attached bed thing if you want to go deeper. But it has the most clinically validated as most accurate sleep scores.
No, you're good on time, Dave. We got 15 more minutes if you could.
Okay. Did you want to leave some time for Q&A?
Oh yeah, absolutely. We can definitely do Q&A.
I can go for 15 more minutes. I just want to make sure we have enough Q&A time.
Yes. Yeah, we're good. Yeah.
Okay. There were also also something else, and this is hard to quantify. In fact, most people aren't going to quantify it, but I think it deserves way more attention in the world of medicine than it gets. And it has to do with those 5 things I briefly mentioned about light. You can measure the angle of light. You can measure the color of light. You can measure the intensity of light. And if you were to track those things, and there's a few apps on the phone, they aren't very good yet. And there's a few multi-$1,000 devices that can track this that are better, but those are mostly for lab use. So those are things that are up and coming. What you'll find is that if you block violet, you block amber, you block green, and you block blue, those are the 4 frequencies of light that are clinically validated to talk through the melanopsin sensors to the SCN in your brain, which controls your central clock. So if you have a patient who says, I bought blue blockers, they're only using blue blocking to change melatonin production, but unfortunately, they're still getting a wake-up signal. So people are asking in the questions, what glasses do I use? I actually wrote the patent on this, so I did a lot of research. This is for the company called TrueDark, which is one of my portfolio companies. But the idea here is even if you're not doing the glasses that fit all those things in, you tell your patients, get red lights for the bathroom at night if it's a night light, especially if there's any children involved, it matters more for them. And if you have red lights, you put them low to the ground. Because if you think about this from mitochondrial biology, 2 billion years ago, little bacteria floating in the ocean, when there's sun overhead with full spectrum light, that's the middle of the day. Oh, and then when is the most algae to eat available? Between noon and 2 p.m. when there was the most sunlight. So the biggest signals for your entire system clock to align itself are light angle, color, and intensity. And it's sunset. Oh, it's red light in front of me. Oh, it's daytime. It's red and all the other lights above me. Really, really big difference. And then food availability. So if you eat a ton of food at the end of the day and you have bright lights, it's no wonder you're dysregulating 2 different clocks. The third thing that influences your clock is temperature. And you can measure this with an Oura ring. It'll tell you your body temperature fluctuations. I've seen really good results from people using systems like Chili Sleep or 8 Sleep that chill their mattress. This is another quantified self angle where data now shows that if you have a cooler mattress for the first half of your sleep cycle, you will get more deep sleep. And in the second half of your sleep cycle, if your mattress or your room is at exactly the right temperature, not too hot, not too cold, you get more REM sleep. I'm to the point where in 6.5 hours of sleep on average for the past 10 plus years, I get at least 90 minutes of deep sleep and 90 minutes of REM sleep. And quite often I'll sleep 5 hours a night if something is happening in life for me, and I still get those same amounts of deep and REM sleep. Temperature control and lighting control and food timing are the things that drive that, which also increase heart rate variability. And what your patients will find, and what you'll find if you go down the quantified self path, is like, wow, I can get more sleep in less time if you believe in those measures of sleep quality, which I clearly do, because the study is showing things like growth hormone and whatnot. More deep sleep, more growth hormone, more deep sleep, more testosterone, et cetera, et cetera. There's some of the stuff in the future that's coming that I think is worth talking about. And it's one of the questions here from Cami. What do I think of the AO scan? There have been a variety of research groups. A ton of this comes from Russia. And guys, I know that's politically correct to hate anything from Russia. I'm just going to say Russians have some of the best biohacking science going back to the 60s because of their astronaut program. And science is not political. Science is about the quest for truth, wherever it comes from. So Russians, East Germans, Japanese, and a few places in China more recently, they've been looking at what is the electrical signal that comes off the body? And how do we correlate that? There's a company called NES Health, and they're actually looking at the Chinese pulse system and also the Tibetan medicine pulse system that's slightly different, as well as Ayurvedic, where you look not just at how many beats per minute, but a lot of the other variables for it, and looking at what you can do to electrically measure that. So we're right on the cusp of an explosion of ability to measure things on the skin. And the history of this goes to EAV, Vega scans, and lots of other things. Right now, the body's spitting out information all over the place electrically, even with radio frequencies and light. And we're just figuring out how to get enough of that data into systems to apply machine learning to get the real knowledge in there that we've been hinting at and seeking for thousands of years in traditional systems of medicine. So this is like a 3-year kind of a problem. A company called Energy for Life is doing some really good work around that. Something else that's very powerful that isn't necessarily quite quantified, but still numerical and worth mentioning is the pulsing of light. So before I talked about the variables of light that set your timing system, well, there's more, because if lights pulse, something else happens. And I looked at this first because True Light, which is my light therapy company, we pulse the lights because you can have a higher dose of light without overheating if you blink the lights. But it turns out the rate of blinking can have profound biological effects. The first study of this is a researcher out of Harvard who figured out that 40 pulses per second, 40 hertz, actually generated, surprisingly, a reduction, a very meaningful reduction in the tangles that are common in Alzheimer's disease. So she is reversing those brain problems with 40 hertz lights of any frequency. So we are going to see coming up here a lot of companies pulsing lights at very specific frequencies with profound results that you can measure with quantified self, but it's more about the device manufacturer knowing how to pulse it. We're also seeing companies like HAPBee, HAPBEE, who are pulsing electromagnetic frequencies in ways that are tested on mice with very, very statistically significant results. Mice are not subject to placebo. They also work on humans. So we're suddenly understanding that our systems are sensitive to all these environmental variables. And the original definition of biohacking was the art and science of changing the environment around you and inside of you so you have full control of your biology. That means not being sick. It means not getting sick. It means being more resilient. It means getting more sleep in less time. Basically knowing you have more energy than you need to handle anything life brings your way. And some of the things I'm getting at towards the end of my presentation here are, what does the future look like and what can we do? But it'll always change those core variables. There's another question here about hypnosis. Hypnosis can have profound effects, especially on deep sleep, REM sleep. I've seen countless people who've had hypnosis work done who completely changes their sleep response, which changes their inflammation markers even. And I've interviewed Dr. Daniel P. Brown, who's also a Harvard guy, on my show on the Human Upgrade. It's not renamed from Bulletproof Radio. And we talked about hypnosis and its clinical effects. The guy's 40 years of very high-end medical hypnosis under his belt. And it's a real thing. I was very skeptical of this when I was younger and a computer hacker. But if you have the right hypnotist and the right patient, it can be completely amazing what it does. You will see those results in your quantified self results. This is one of the things, if a patient's skeptical, well, hey, you can try it. It's unlikely to hurt you if it doesn't work, because then it's just someone talking to you. But if you do it and then you see a change in whatever score you track, maybe you can trust it. And that's really where quantified self shines. There's another question from Jennifer about TMS, transcranial magnetic stimulation, because it increases BDNF. It turns out I've used that for about 5 years at 40 Years of Zen to increase BDNF. And there's high-powered TMS, which I did for a podcast once. These are the $250,000 machines that you use to treat people with clinical depression. It doesn't need to be that strong. There are clinical grade systems under $25,000 that with a very well-trained operator, you can have profound cognitive changes from pulsed electromagnetics on the head. The systems that I use at Upgrade Labs are usually the very high-powered system for bone density, which is also a great marker for metabolic function. These are things that are so strong they are triggering current on cell membrane, so your arm will twitch when you're on it. They work very well for systemic pain and inflammation. All right. Other questions that you had kind of coming through here. Best ways to get labs done personally versus ordering them for a patient or client. This is from Susan, who I'm guessing is not an MD. Most labs now that you want to get, you can order online. And in some parts of the world, there's like any lab test now where you can do it. But I recommend to people who can afford it that it's worth partnering with a functional medicine doctor, whether you order your labs yourself, to interpret them. We have more information now. I used to say from Dr. Google, but Google is actually the worst place to find any useful health advice anymore. You want to go to DuckDuckGo or somewhere. I can't write my books using Google because I can't find any relevant research. It's all kind of like Reader's Digest health stuff. So I would just say for people who are very high-end personal biohackers, yes, you can get your labs wherever you want, but do have a partner on this, especially for brain stuff. And this is one thing that concerns me. I thought my first EEG clinical system in the late 90s after I saw how powerful it was, and I started using it on myself. Gee, it's like doing brain surgery on yourself. This stuff is really powerful. So I think it needs either really strong algorithms or adult supervision so people don't harm themselves. But I do believe people have a right to do what they want to do to their brains. All right. And I'm getting a question here from Keith about 3 most important things based on all of this. Most important thing is don't do just one thing to get results. Do the things that are less likely to conflict with each other that all might get results, because the result is most important for you or for your patient. And that's assuming that the amount of work, the amount of energy, and the amount of money that is spent on that is within whatever the patient's willing to do. You will very likely see changes that way, and then you can back off. So that's the first thing from a quantified self biohacking perspective. The second thing is, if you can get high quality sleep with a higher heart rate variability, the sum total of what you're doing is working. Even if some of what you're doing is not productive or even counterproductive, you're still net winning. And the third thing I would do is I would reiterate sleep quality monitoring and continuous glucose monitoring as the 2 most lowest hanging technologies to really improve your awareness and your behavior change, because one gives you feedback after 6 or 8 hours, and the other one gives you feedback every day, multiple times throughout your meals. Is it a good time to do some other Q&A?
Yeah. Yes, perfect. Yeah, thank you, Dave. I think that was very interesting presentation. I think you made a lot of good points. I see a question coming in about PEMF mats and your opinion on those.
It's really interesting. So many companies are making PEMF devices here that there's different form factors. There's mats, there's big coils, there's the headsets and things like that. There's one set of PEMF is around getting a specific signal to do something into the body. And these are things like Happy, like NES Health, where you're not necessarily going to feel it. Or a company called Halo, H-A-E-L-O. These all make things that you can, oh, I get it. And then there's another set of things that are really powerful where you sit on it and it's not quite pain, but you can feel really strong stimulation. They just do very different things. The mats I've seen are usually very gentle PEMF. It's more of the kind that could put you to sleep. I have spent $5,000 on mats that I couldn't tell ever did anything, even though they had lots of cool settings on them. And I've seen some that are reasonably relaxing. So I would say, more than worrying about whether it's a mat or a pillow or whatever else, is it a quality company that has good signals and good research behind what signals they're sending in? How are the PEMFs changing? Versus a company that's doing very powerful, where it's a question of how much strength can I get in? If you're looking for injury repair and metabolic stimulation, I mean, healing of bones is incredible high-powered PEMF, like almost unheard of superhuman sort of things. I'm about to release a little mini documentary about healing from bone surgery twice as fast as you're supposed to, and PEMF was part of that, but it was the higher.
Okay, interesting. And I thought you made a great point as well about sleep and sleep trackers sometimes having a counterproductive effect. I had a patient recently that I saw in the morning, and she said she was feeling off. And when I talked to her, it turned out that she had felt very good waking up. And then for the first hour of the day, then she checked her sleep tracker, and it said she had a very poor night of sleep. And then that sort of translated to, then fatigue and wondering, like anxiety and, not trusting her own experience of sleep versus looking at the tracker. So do you have any comments on that?
I actually really like hypnosis for that. I mean, this is a highly anxious person who's a perfectionist, right? And it's, oh no, I failed, therefore I'm a bad person. And what really works well for that also is EMDR, right? There's a time when she failed and someone yelled at her, and that's getting activated by that. It's just the device yelling at her. So when people do either EMDR or deep neurofeedback sort of things or hypnosis to let go of that, it's not going to just change their response to tracking their sleep. It's going to change their response to criticism in their entire life. And I think you'll see broad changes in stress and inflammation when those people drop all that garbage. And I'm only saying that because I was one of those people.
Yeah, I think that's a great point, because I think that reaction that she was having, it really seemed out of proportion, and I think it probably was from some earlier event in her life, and I think that is often missed when we're seeing the emotional reactions that people have. So yeah, I think that's a great point.
From a physician perspective, just to follow up on that. Some people are better at hiding that than others. When I first went in to try and get a brain scan to figure out what was going on when I was failing out of Wharton Business School, the psychiatrist that I saw was like one of these Ivy League dudes trying to get Adderall. Like, I know the type, you all know the type. And when he saw my brain scan results, he just said, I don't even know how you're standing here in front of me. Your brain's total chaos. You have the best camouflage I've ever seen. So you're going to see some people who, like your patient today, they present that way, and there's another group of people who are just hiding it, and they actually have more anxiety than the other ones. And if you find someone who's getting that, even if they're not acknowledging the level of things that she experienced, it's probably a part of it. So don't fall into this stereotype thing like, oh, that's obviously a tweaker, because there's some people who are high performers, and I've had 1,200 of them go through my neuroscience program, and it's amazing how many highly successful people are just hiding stuff. They're successful because they're trying to not fail again. And so you can have that patient population, but they're harder to spot.
Makes sense. Yeah. And what's your opinion about some of the different ways to measure biological age? I know you like telomeres versus methylation. I mean, there's so many out there now. What do you think?
I was fortunate to spend a couple days with Steve Horvath, who did the primary, or say most studied clock on methylation aging. I am not a huge fan of telomeres. I have seen too many people doing upgrade labs come in and say, look, I lost 20 years in 1 month. No, you didn't. Telomeres in blood vary very, very widely with short interventions. So you get a blood test to get telomeres, it's just not that reliable. Not many of us want to do a punch biopsy to get muscle telomeres, and they're provably different than heart and brain, which are probably the ones you care about the most, or maybe liver or kidneys are kind of important, but let's not puncture those organs unnecessarily, right? So I'm a little skeptical on telomeres. I've also had 10-year swing over the course of a week in tests. I just don't believe that. So that leads us to methylation, and the True Age score from True Diagnostics is one I appreciate because I think their science is solid, and they let you choose the clock you want to use, and they've got intrinsic and extrinsic and kind of total biological age. And I mentioned my 11.25, which I think was my intrinsic score. My average from them using multiple clocks was about 6 years younger biologically than my chronological age. And given where I came from a health perspective, I'm feeling very, very positive about that.
And that's a blood sample you send in?
It's a blood sample from True Diagnostics with their True Age report. It's the best one I've seen so far. The second runner-up would actually be from Viome. I like Viome a lot. And again, because I am an early advisor and investor, I've spent time with their chief scientists. I've gone deep on the tech, but also I could be biased because I have a business relationship. But It will not change my life if you don't get a Viome test. I'm just going to talk about it. And what Viome has done is they always sell their tests at the cost of running the test, because the data is really where they're discovering new things. And they're also now have custom probiotics and supplements and things like that. So it's a very affordable test. I think it's 149 or $200 or something, depending. But they're looking at mitochondrial biology, and they're coming up with a pretty good age number that is based on a sum of mitochondrial function, what's going on in your gut, what's going on in your immune system. So it's called something like total health score. But in terms of cost and accuracy, they probably outperform TrueAge, because TrueAge is more expensive, even though it's more accurate. So as a low-hanging fruit, I like Viome. As the most pinpointed, I like TrueAge.
Okay. Okay, great. So we have a question coming in from Antonio Guimares in Rio de Janeiro. Thank you, Antonio, for your question. Dave, what would a perfect day look like when shooting for longevity in terms of wake up time, meal timing, exercise, routine, stress management, and bedtime?
I like to wake up about when the sun comes up. And it's really important. And now actually some very recent studies came out about this. So Andrew Huberman is talking about it. It's back to what I talked about with angle of light. If you get morning light in your eyes, it sets your circadian clock for the entire day. So if you can get even 5 minutes of light, 20 is better, but let's not be perfect. And if you can get it without windows, and especially without UV blocking contact lenses or glasses. So getting some ultraviolet light in actually is good for you. You don't need full UV blocking all the time. UV actually improves eye health as long as you're getting a normal and small dose. So morning and evening light is very important. So I would say wake up around when the sun comes up. Some people have genetics, about 15% of people, that make someone wake up at 5 a.m. and be all bouncy and bushy-tailed. And they have convinced the rest of us that they're morally superior. It turns out there's 15% of us that are also more late night people. But regardless, if you have bright lights at night, our genes set those 15% of people up. And as Dr. Michael Bruce is writing in Sleep, which is really good. But when we lived in caves, this was the people genetically wired to be the night watch. But they were the night watch in darkness. So if you're saying, oh, I'm a night owl and I'm going to turn all the lights on, you're just a bad sleeper is what you are. But if you need to go to bed at 11 or even 12 and you had red lights or no light on at night and you dimmed all your screens and did your thing, that's actually okay. And I'm one of those genetically, but with what I just talked about with all those 5 variables of light, as long as I do that in my meal timing, I go to bed at 10:30 like most people for the first time in my life after 40 years of going to bed at 2:02 a.m. was my average. So you can shift it, but that's really important. After that, number one thing is you can look at your phone to get your sleep score. I do that every morning, but it's in airplane mode. And you don't take it out of airplane mode because you need that first half hour just to think about what you just dreamed about and to process. If instead you let Google's AI algorithms tell you the news of the day and you let other people set your agenda with text messages, your stress levels will go up and you will quantifiably lower your quality of life. And timing a first meal, intermittent fasting has been a part of the Bulletproof diet since 2011. And there's 3 things you can do during intermittent fast. And this goes more to my most recent book, Fast This Way. But people who have a hard time fasting, black coffee doubles ketone production. Coffee or tea or whatever it is with prebiotic fiber won't raise insulin or mTOR. It works very well. Or you can add butter and MCT oil, both of which hold insulin and mTOR constant or let them fall. So your body still gets the effects of fasting. So I usually have one of those 3 things, or sometimes all 3 in the morning, depending on the intensity of my day, and maybe some green tea too. It's good for you. I don't eat until 1 or 2 in the afternoon. The bulk of my calories is around 1 to 2. And then I usually eat at dinner because of social things. I set my dinner to 5:30 whenever I can. And I don't eat after 5:30 most nights. And what a difference in sleep quality and just quality of life. It is a bit jarring if you're used to having business dinners at 7:30 or 8. I just eat the salad. That's what I do. Just don't eat. In terms of stress management, it's a good thing in the morning to journal or meditate. Or I used to wake up earlier and I would do art of living breathing exercises, which is about 40 or 50 million people. It's primarily out of India do, and then that in Silicon Valley. It's about a 15-minute set of breathing exercises to get air into different parts of the lungs, including some that looks a lot like Wim Hof breathing now. But then you have kids. And let's just be really clear. Most of your patients who have kids, and you, if you have kids, you probably don't have that morning routine because they start school at a time that damages kids' circadian biology. So there's an ideal one, Antonio, but if you have a family, it's bottom line is just don't turn on your text messaging until you drop your kids off at school. That'll change your entire life, right? And if you wanted to quantify that to see what it does, then you can actually have either probably would be a journal that says, when did I take my phone out of airplane? Do it for 2 weeks and you'll be amazed at how much more relaxed you are because you actually focused on your family when they were done. As soon as they drop off at school, turn it on, let it come in. Maybe you meditate, maybe you don't. If you have younger kids, they're programmed to sense when you wake up. It doesn't matter when you wake up. Your 2-year-old will wake up then when you try to meditate and come and mess with you. It's okay. That's part of meditation in life as well. But I just want to call that out. There's ideal, but most people don't get ideal because of school and kids. In terms of stress management practices and bedtime when you're shooting for longevity, just learning how to breathe and how to sense your stress levels is really important. The lowest hanging fruit there is heart rate variability training from HeartMath. It's very affordable. And I've coached hedge fund billionaires and others on how to do this. The reason is that you get a sense when your body goes into sympathetic mode that you're not trained to know otherwise. And when you realize, oh my God, it's happening all the time, that's when the light would have turned red when you're doing the training, then you can say, I'm going to do the thing that makes the light turn green. And that works really, really well for stress management. Because I've done that, and I've done 6 months of deep neurofeedback because I happen to own a neurofeedback company. My stress management is built into my day. Like there's a constant meta awareness. I don't have the main voice in my head anymore. But for most of us, even 5 minutes of conscious breathing is really, really important. And maybe layer in some either a hypnosis track when you go to bed or layer in some other form of things that makes you feel good. Like maybe it's EEG. You will find with most of these training things, especially HeartMath, like you do it for 6 weeks till you're a master, then do it once a year. You don't have to do this training all the time. And that's a really important thing to understand. Sometimes it's just about teaching your body to behave itself. I didn't also talk about functional movement, but many of your patients, and probably you, have muscles you don't use because you forgot how or you never learned how. And a lot of this has to do with infant development, crawling reflexes, as well as injuries and trauma from injuries. So sometimes a little bit of functional movement work can go a long way towards lowering systemic stress because suddenly people are walking and their pelvis is getting tweaked all the time. Stuff like that probably belongs, it should get an honorable mention here, as well as mineral balance in the morning. Sodium is really good for you in the morning. And when I had adrenal dysfunction, having half a teaspoon of salt from a mine somewhere, whether it's Redmond or the Himalayas, in water is really good for you, but I am magnesium and potassium adequate. It's not good for you if you're depleted in those other minerals. So my next book will have a bunch about mineral balance because it's so important, as well as trace minerals. You guys wouldn't know this, but there's studies showing giving people trace minerals is as effective at lowering inflammation as a dose of cortisol. So most of us are depleted in those minerals. But again, from a longevity practice, you need adequate minerals, adequate fat-soluble vitamins, adequate saturated fat, and adequate DHA and EPA, and not too much omega-6 and a decent amount of oleic acid. If you do that and you don't eat in a very big window most of the time, and when you're really stressed, you do have carbs because your body needs them, and you cycle in and out of ketosis, so you don't always do it, that's what's going to build your longevity.
Wow, that was a very complete answer. So thank you. Thank you for that. So maybe we'll just take a couple of final questions. So one is about food cravings. Often, occur at night. Any thoughts about how to approach those?
I love this. Pretty much my last book was all about food cravings because I had them profoundly. And if you have a food craving, it is 100% your fault. And 90% of it is just look at your meal beforehand. You ate something that caused inflammation or caused stress on your microbiome. And a microbiome that's trained to eat sugar, when it doesn't get sugar, it gets stressed. When bacteria in your gut get stressed, they manufacture a substance called LPS, or lipopolysaccharide. Lipopolysaccharide crosses your gut barrier and creates stress and inflammation in the brain. When the brain is stressed and inflamed, it tells you to make or to eat sugar. It wants you to eat sugar so it can have more glucose so it can start working on the stress and inflammation in the brain. because your glial cells in the brain prefer glucose, even though your neurons prefer ketones. So you look at what you ate and you say, oh, did you eat that improperly prepared, the lentils, the quinoa? It turns out it's really hard to prepare those in a way that doesn't deplete you from minerals and create inflammation. It can be done, but most people don't pressure cook and soak and ferment and do all the stuff it takes to eat those hard to digest foods. So you basically ate something, or the fried whatever, it was the omega-6s. So when you start tweaking what you eat, you shouldn't think about food for 4 hours after a meal. And if you do that, wow, that's amazing. But most people snack all the time because they're continuously eating things that cause food cravings. The other part of it is emotional eating. So it's not triggered by gut bacteria that are dysregulated and giving you LPS, which causes a food craving. It can be caused by blood sugar swings. But generally, if you have a meal with meaningful amounts of soluble and insoluble fiber, with meaningful amounts of undamaged, saturated, and monounsaturated fats, and adequate high-quality protein, you're not going to care about food for 4 hours. So if the cravings are coming, just look at your dinner. I promise you that Impossible Burger gave you cravings.
Right. Yeah, that's a great point. Okay, and then question about where to get whole body testing. I think this question probably about imaging, places that you might recommend.
So if you're looking for imaging, it's fascinating, which is what you can do with this now. There are companies that have rewritten the algorithms for MRI machines so that they can do very, very early cancer detection. They can look for vascular changes, and it's fascinating. So one of the companies that does this is Prenuvo, that I've had done, which is pretty good. And there's about 5 or 6 others who are now doing whole body diagnostics. Peter Diamandis and Tony Robbins recommend one in their book, whose name I am not recollecting. And if I looked at my phone, I have a list of 6 others, but I don't remember them off the top of my head. I haven't done them yet. I'll do most of them just to see what the differences are. I think it's really, really useful to get this at least once. You might find something like I did, like, oh, I only have 1 kidney. I wouldn't have known because the one I have works just fine. But knowing that it's not there is useful, or particularly things like as we age, how your spinal cord and your discs are doing, really, really valuable information, because then you can go get stem cells, or you can do an ozone injection or use PEMF, but you can now hit your areas of weakness. And it goes back to the overall arch thing, track what you hack. Well, if you don't know somebody needs hacking because you haven't done imaging, then you're not going to go work on it. And it may just be, doing specific stretching exercises, or it may be getting a tumor looked at that you couldn't see before. So I think there's great value to these, but they cost a couple $1,000s, and it's usually HSA, but not covered by insurance.
I see. Okay. Well, Dave, thank you so much for incredible talk and spending time with us on a Saturday. This was super helpful. It's a lot of great comments, gratitude coming in. So thank you for taking the time and presenting with us today.
Well, thanks for putting on a great conference to help a lot of people. This knowledge is part of the human operating system, so we should all have it. And thank you again for sharing.
Okay, thank you so much, Dave. Okay, so now just to wrap up our event, thank you for staying with us till the end of the day. We're always interested in your feedback, especially about whether you prefer the online format or in person. So if you could post in the chat, let's say for next year, would you prefer the conference to remain online or to be in person? We'll be going back and taking a look at the chat later. And we really hope you gained value from all these high quality presentations. So we'll be sending out an email probably a couple of weeks after this event with links to watch the replay and download the PDFs of all the presentations. And we will have Rob Wolf's presentations as well at that time. So sorry for the inconvenience that he was not able to present today, but that material will definitely be included in terms of the final wrap up of the symposium. Yeah, we hope you enjoyed the event. If you would like to be notified about next year's symposium by email, then please sign up for the email list at drakil.com. That's doctorakil.com. So that's a list that I maintain that is pretty infrequent mailings, but one of the things every spring we do notify people about this symposium. And today's event would not have been possible without our sponsors. We'd like to thank the Sutter Health Institute for Health and Healing and the Roberta Neustaedter Mini Medical School Fund for supporting education in integrative medicine. Thanks to all of our speakers, and thanks to all of you for attending today. So we know these are very difficult and challenging times in the world with everything going on. So with all the stress that's out there, we wish you the best in terms of health and safety. And so don't be socially isolated, remain connected to your friends, colleagues, and family. Wishing you a safe, happy, and healthy rest of the year. And hopefully we'll see you again at the 2023 symposium. So thank you again, and bye for now.
Hi, everybody. Rob Wolf here. Hey, really honored that you're taking the time to check out my second look at sodium, or another look at sodium. Sodium's one of these funny things that has seemed to be in and out of health contention. I think that for a good period of time, it seemed like, sodium was maybe not public enemy number one, but it seemed like there was a very airtight case related to sodium intake and its negative effects on health, ranging from different types of cancers all the way, of course, to cardiovascular disease. But it's interesting. Over time, there's been back and forth on this topic. It seems like it's a very open and shut case, and then at other points, it seems like there's a bit more to the story. It's a little bit reminiscent to me about the cholesterol, lipoprotein, cardiovascular disease story. And again, a big part of this piece as we look at sodium and its effects on health and maybe even benefits with regards to health, it's reminiscent of the story around cholesterol and cardiovascular disease, which makes me think that there's probably a more nuanced, more detailed picture emerging here. Like for arguably most of the cardiovascular disease is driven by cholesterol story. We were ignoring the whole lipoprotein piece of that, picture, the fact that cholesterol is carried by lipoprotein. So there's an association there. There's clearly something going on. And like if you're in the vascular endothelial damage model, which is a little bit different than the cholesterol hypothesis, you still need cholesterol or lipoproteins, LDL lipoprotein, to be a factor in the atherogenic progression. So there is something to that. I think we see some similar stories here with sodium. So anyway, I'll try to get this thing going. We kind of have three parts to this. We have a little bit of fluffy gee whiz stuff in the beginning, just some kind of Guinness Book of World Records type stuff around sodium. The second part really digs into the common concerns around sodium intake in different disease states. But again, we're mainly going to be looking at cardiovascular disease considerations, kind of going back and doing a little bit of archaeological digging in the medical records to see what is there with regards to sodium and its impacts on our health. And then finally, once we dig into that, and I kind of, clearly I have my bias in this story, and I kind of lay out a case about where I think that sodium plays out in this health story. Then we have a few other considerations like athletic populations, low carb populations, and stuff like that. So a little bit of the geez whiz stuff. Is sodium important? It absolutely is. We frequently forget that sodium is a critical nutrient. If we don't have adequate amounts of it, we will die. The average person, and clearly this is going to vary based off of, size of this person, but, about a 50 kilogram person has about 40 teaspoons, about 200 grams of sodium chloride in their person. Yearly, the global trade in sodium chloride salt of various kinds is $3 to $4 billion per year. This this thing about 6,000 years old really relates to the oldest archaeologically discovered instances of mining and trading of salt. It's hilarious, and I meant to add this to this talk, but I had forgotten to do it. But there was a label of a really, higher end, specialty salt, and it said that the salt is 200 million years old, and it had an expiration date of like 2 years, which was just hilarious. But I find some irony there. One other gee whiz thing, the most expensive type of salt I've been able to dig up is the 9 times roasted bamboo salt. It has turned this kind of white grayish color to purple. It's really rather beautiful, and this stuff goes for $200 to $300 a kilogram. So that seems to be about the most expensive stuff that there is. I think some of the other gee whiz stuff around sodium is just that all of life is arguably driven by sodium potassium pumps. Like at our most fundamental level, particularly for complex organisms, but even for single-celled organisms, so much of the energy that's produced, the process of liberating ATP, so much that goes into that is driving these gradients of sodium and potassium within cells and outside of cells, and it is this that allows us to think and to move. It is the firing of nerve impulses, the action potential of a nerve or muscle. So literally every bit of life is kind of boiled down to the activity of sodium potassium pumps. Like you could really look at us as kind of a bioelectrical battery of sorts, driven at this cellular level. I think I beat that pretty well to death. This is it's interesting that even part of what I was wanting the point that I wanted to make with this, in addition to life generally being driven by these sodium potassium pumps, even this kind of edge part of life turning into death or avoiding senescence is driven in large part. Autophagy is driven by utilization of sodium potassium pumps. So I just find it to be a really fascinating topic and so simple on the one hand, because I think most people are exposed to at least this basic concept of sodium potassium pumps, like in like a high school, grade school biology type class, and its importance never really changes. And we're going to look at some of the most critical health concerns facing the westernized world, and a lot of it ends up boiling down to this kind of sodium potassium ratios and whatnot. So some of the concerns in the studies that support these concerns, really at base, the primary concern around sodium and its intake seems to be related to hypertension, and within current medical circles. It's interesting that when I really dug into the oldest medical literature that I could find, the old material really didn't look at sodium in a negative light. It was looking at, and this was, early. This paper is from 1859, where we're doing basically some quantitative chemistry, looking at sodium, urea, and water excretion while experiencing a significant fever situation. But it's interesting. I really tried to go as old as I could on this material and see when and where the presence of sodium in the kind of medical literature took any type of a negative turn, and particularly a turn towards an association with hypertension and cardiovascular disease. And the earliest piece that I could find, and this is digging into some of the more recent search returns, and it shows where we have papers all the way from 1859 to the present day. But the The earliest piece that I could find is this one from, I believe it is 1946. Yes. And it's interesting because, again, this is the first kind of medical literature piece that I could find that was making either an association or at least a recommendation of restricting sodium as a treatment for hypertension. Part of what's interesting in this, and I had neglected to look into this, and because it was a bit tangential, I'm not even totally sure within the medical circles when we started quantifying blood pressure. I know the mercury-based blood pressure cuffs and whatnot. I think it was like a late Victorian era development, but when did we even start looking at and tracking blood pressure? That was something I kind of wanted to look at as it relates to this. But, is sodium important with regards to blood pressure? And it clearly is. There's, as I mentioned before, there is definitely something going on here. And so in this paper, Survival in Treated Hypertension, a follow-up study after 2 decades, this paper looked at folks who have been diagnosed with hypertension. They are treated over the long haul. And what's interesting here is that treated hypertensive individuals, and this was actually mainly men that they looked at, still had impaired survivability from cardiovascular disease relative to non-hypertensive individuals. So there is something clearly to elevated blood pressure causing damage to the vascular endothelium. And this is maybe worth just backing up and mentioning really quickly. Atherosclerotic lesions seem to only occur on the pressurized arterial side of the vasculature. To my knowledge, we don't see any of the atherosclerotic plaque formation, even in like familial hypercholesterolemia or in sickle cell anemia, which can cause really significant damage to the vascular endothelium. I don't believe that we see any examples of accelerated or really any presence of atherosclerotic lesions in that non-pressurized side. So this is why the blood pressure and hypertension is such an important consideration in this story. Cardiovascular disease continues to be one of, if not the primary, killer of individuals in westernized societies. And whether you're more in that damage to the vascular endothelial model or the cholesterol hypothesis model, clearly non-laminar flow and turbulent flow ends up causing damage to the vascular endothelium. So there is definitely something important here. And this paper is interesting to me in that it shows that even treating these folks down to close to normal levels doesn't really improve total outcomes. And I think we see that with a lot of things like glucophage it's helpful for diabetics, but if the individual continues to overeat, we still don't see that really robust improvement in total lifespan that we would like to see if somebody is able to, spontaneously control their blood glucose levels more efficiently. So, sodium is definitely a player in hypertension. Hypertension is clearly a factor in the cardiovascular disease process, but it seems like there's a lot more to it than just that. Raised blood pressure is responsible for at least nearly 8 million deaths per year worldwide, more than any other risk factor. About 54% of stroke and 47% of coronary heart disease is attributable to high blood pressure, according to this paper. And I'm interested how they kind of parse that stuff out, given that folks with normotensive, blood pressure, it seems like their rates of these disease states are remarkably low. But also, I think it's worth mentioning that the cut points that are oftentimes used are what's normal within a westernized population may not be all that healthy. In 1 minute, I'm going to take a sip of water. So I'd mentioned that part with the abstract. So hypertension is clearly a major problem. Sodium is a player in blood pressure regulation. Fluid volume is definitely maintained via adequate levels of sodium. Over retention of sodium can definitely lead into hypertension, but is sodium really the driver of hypertension, or is it a bystander or a byproduct of the whole process? I'm going to kind of jump to what I think is the real driver, and then we're going to work backwards from there and look at some of these other pieces. I think that the metabolically driven hypertension model makes a lot of sense. Within the metabolic syndrome state, we have increased blood pressure, we have high triglycerides, we have low good, quote, HDL, we have elevated fasting blood sugars. And as we'll see in these other papers, within the metabolic syndrome state, we also have a hormonally driven increased retention of sodium, which can directly lead to increased blood pressure. We have some interesting vascular effects from stimulating the autonomic nervous system, causing vascular tension and increased blood pressure. And we just have a heightened arousal state, increased cortisol and epinephrine within this metabolic syndrome state. So it's interesting that when we think about just blood pressure, there are multiple mechanisms within the metabolic syndrome condition that are fostered or worsened from that, versus just looking in increased sodium retention and therefore increased blood pressure is one piece of that. But when we're looking at just sodium as a standalone, that's kind of the only piece, versus this metabolic syndrome picture, which is pretty comprehensive and ends up layering in multiple layers or different mechanisms of driving that cardiovascular disease potential via hypertension. And it's also worth mentioning that when people fix metabolic syndrome, this might also be why we see so many different avenues for mitigating this cardiovascular disease state. So the role of insulin resistance in essential hypertension from the discussion is believed that insulin resistance could cause hypertension through compensatory hyperinsulinemia. Insulin has been shown to stimulate the sympathetic nervous system, increase renal sodium retention, modulate cation transport, and induce hypertrophy of vascular smooth muscle. So, is it really only sodium as a driver of these, the hypertensive and cardiovascular disease process? Or does it make more sense that we have a multi-pronged issue coming at us from metabolic syndrome? And I don't know how powerfully this plays into the discussion, but it was several years ago that a paper was published that suggested that fewer than 12% of Americans are considered metabolically healthy. So this kind of underlying metabolic disease that would have a multifactorial input on hypertension and cardiovascular disease risk makes a lot of sense, and we'll see if we can unpack a little bit more of that as we go along. So part of the history of where the sodium intake equals hypertension, which leads to cardiovascular disease, came from a scientist, Lewis Dahl, and the story is somewhat reminiscent of the Ansel Keys story, in that you had a kind of very smart, highly motivated scientist who got in and started doing what is arguably some pretty interesting research. But what the Lewis Dahl, the Dahl rat studies did is he found a sodium sensitive breed of rats. Oh, excuse me, I moved that forward. And what happened here is that there started being a kind of selective breeding for sodium sensitive hypertension within this rodent model. And these animals were fed remarkably high amounts of sodium. And not surprisingly, these animals developed hypertension and associated cardiovascular disease problems, including kidney damage, accelerated atherosclerotic plaquing, and things that we would normally associate with hypertension. But even at the time that this material was released, a lot of folks in the scientific community were really skeptical that this had much to say or much input for humans, other than there are definitely some humans that are sodium sensitive hyper-responders, although it also looks like these folks are particularly prone to metabolic syndrome also. So it becomes a little bit of a question, is it specifically the sodium sensitive piece of this story, or is it actually the underlying metabolic syndrome? But the Lewis Dahl studies was really kind of a beginning of deeper scrutiny around the intake of sodium and cardiovascular disease as it relates to hypertension. But again, similar to the Ansel Keys story, the scientific community was not sold on this uniformly. There was definitely some sort of association here. There was something interesting, but was not uniform. But again, similar to the diet heart hypothesis, this idea really gained a lot of momentum and is kind of at various points been the dominant paradigm, and then it's kind of fallen out of vogue to some degree in certain circles, and we'll get to that near the end of this presentation. So another interesting and important piece is the InterSalt study, which was this massive study, looked at just a huge number of people and sodium intake and associations of various cardiovascular disease endpoints. It was a standardized worldwide epidemiological study of a huge sample size that tested both within a population, men and women. It was looking at 24-hour sodium excretion and blood pressure. There was in this study, a significant positive independent linear relationship between sodium excretion and blood pressure. So this was very compelling at the time, and continues to be, as a benchmark suggesting that sodium intake is this primary driver of blood pressure. And it was an interesting study in that it looked at not just a single population, but it looked all over the world at different populations. And this may have introduced some challenges here. And I'll read a piece from this kind of takedown of the InterSalt study. Although most populations around the world had sodium consumption levels in a narrow region between 100 to 200 millimolar, approximately 2.3 to 4.6 grams of sodium per day, there was an outlier group of primitive tribes that consumed approximately less than a gram per day. A critical conclusion of the study was that those InterSalt populations with very low sodium intakes appeared to have had low median blood pressure, so low prevalence of hypertension and no increase in blood pressure with age, leading to the conclusion that the low levels of hypertension among these tribes was the exclusive result of low salt consumption. When the 4 low-sodium outlier populations were included in the analysis, a direct relationship between sodium intake and blood pressure was established. However, when this same outlier group was not included, there was an inverse relationship noted between sodium and blood pressure for all other populations. So, and this is the kind of the graphic on that. What it's suggesting is that when these non-westernized populations that just within their ancestral diets were not exposed to high levels of sodium routinely, were exposed to high levels of sodium as part of this study, that they experienced significantly increased blood pressure levels. And that's probably not surprising, just given that this is kind of a novel exposure for these people. But what we take away from this, or deeper parts of what this paper suggests, is that once there's an adaptation period and people are habituated to their normal diet, that we don't really see this effect. And in fact, we can see an inverse relationship with sodium intake and blood pressure. And we'll get to that in a bit. But what's interesting is that sodium-restricted diets don't always, and actually seldom, provide kind of a lockstep reduction in blood pressure. And there's a variety of reasons for that, but we'll get to that in a bit. So this paper, dietary sodium intake and cardiovascular mortality controversy resolved, ? Universal reduction in sodium intakes has long been recommended, largely because its proven ability to lower blood pressure for some. However, multiple randomized trials have also demonstrated that similar reductions in sodium increase plasma renin activity and aldosterone secretion, insulin resistance, sympathetic nerve activity, and serum cholesterol and triglyceride levels. Thus, the health consequences reducing sodium cannot be predicted by its impact on any single physiological characteristic, but will reflect the net of conflicting effects. Some 23 observational studies linking sodium intake to cardiovascular outcomes have yielded conflicting results. In subjects with average sodium intakes of less than 4.5 grams per day, most have found an inverse association of intake with outcome. In subjects with an average intake greater than 4.5 grams per day, most reported direct associations. Finally, in two, a J-shaped relationship was detected. In addition, 3 randomized trials have found that heart failure subjects allocated to 1.8 grams of sodium have significantly increased morbidity and mortality compared to those at 2.8 grams per day. So what we've seen more recently in some more, I would argue, sophisticated studies is that there tends to be a U curve or a J-shaped curve with regards to sodium intake and all-cause mortality, morbidity, mortality. And this is across healthy populations. This also seems to exist within more diseased populations. And what's interesting is that it seems to be more dangerous to be on the too low sodium side with regards to morbidity, mortality. It's more severe, the problems at the low end than it is at the higher end. So that's an interesting piece, and that's just kind of a recap. Available clinical evidence supports a J-shaped relation of sodium intake to health outcomes with the possibility of increased risk of cardiovascular disease, morbidity, and mortality at both extremes of intake. For those whose averaging sodium intake broadly surrounds 3.5 grams per day, there is no evidence that altering sodium intake will improve health outcomes. So another piece, blood pressure in adulthood and life expectancy with cardiovascular disease in men and women. Compared with hypertensive, total life expectancy was 5.1 and 4.9 years longer for normotensive men and women. I do just want to reiterate this piece that hypertension is absolutely a huge problem. And I think in some ways we were maybe lulled into complacency with this because things like beta blockers and some of the diuretic formulations had produced some degree of improvement in folks with regards to blood pressure specifically. But then as time went on and we were able to track these folks over time, we found that there really wasn't that stout improvement in morbidity and mortality, that total lifespan wasn't really being enhanced there. Probably a lot of different factors going into that. One is just simply that generally medication doesn't bring folks back down into a legitimately normative range is probably a piece of that. And then there's always, complicating factors with different medications. So something to keep in mind there. Blood pressure changes in 1,600 subjects with and without antihypertensive medication during long-term fasting. Long-term fasts tend to decrease blood pressure in subjects with elevated blood pressure values. This effect persisted during 4 days of stepwise food reintroduction, even when subjects stopped their antihypertensive medication. So it's worth mentioning that fasting, if folks follow my work, they know that I have some concerns around the over-application of fasting. But fasting reduces blood pressure in everybody. If somebody is hypertensive, they will see a blood pressure drop. Normotensive individuals can see pathological blood pressure drops. One of the primary actions in the fasted state is a dramatic reduction in insulin secretion, and effectively this is a crash course in reversing metabolic syndrome. Like arguably we can have really profound effects in that regard within a few days. substantial and sustained improvements in blood pressure and weight loss, lipid profiles from a carbohydrate-restricted diet. This is, the natriuresis of fasting, which is what characterizes a dietary protocol in which we are skipping meals for some, indeterminate period of time, is massively emulated with just simply carbohydrate restriction, particularly a ketogenic diet. And similarly, we see pretty significant blood pressure reductions in most protocols in which people are following a low-carb diet. I think that this is one of these stories also where if we were to track folks and their relative blood pressure improvement and their ketone levels, although I don't always or seldom recommend chasing ketones, I think this is one of those situations where it would give us a pretty good insight. If somebody is producing adequate ketones, then we know that we are not getting enough of a glycemic load or an insulin load to continuing fostering the retention of sodium and therefore blood pressure. As mentioned in the introduction, a low-carb diet may improve both hyperinsulinemia and insulin resistance, promoting the loss of sodium in the urine, so improving blood pressure. This may explain our adjusted average 1.6 millimeter reduction in systolic blood pressure per 1 kilogram reduction in weight, which is really impressive and also makes the case for if folks are carrying excess body weight and they are also hypertensive and showing signs of metabolic syndrome, then there's just so many good reasons why the individual would want to embark on maybe some type of a time-restricted eating schedule and or time-restricted eating plus carbohydrate restriction. This is an angle also which maybe gets a little bit further afield, and there's a lot of discussion around sodium and glucose intake, but this is an important piece to this story in that high sodium promotes natriuresis and the removal of glucose from the circulatory system into the urine. This is a mechanism at the kidney level where the hypertensive state, and I'm gonna back up here a little bit. I scooted forward too soon. This is just a more detailed mechanism for how insulin resistance can drive sodium retention and therefore the worsening effects of metabolic syndrome. Because in this scenario, not only do we retain sodium, but that retained sodium also fosters a kind of misallocation of circulatory glucose. So it's a pretty cool paper, definitely worth checking out. Sodium intake, life expectancy, and all-cause mortality. This is where we start pulling back out and looking at a little bit more of a big picture story. What I find interesting, and I'll read this piece here. Since dietary sodium intake has been identified as a risk factor for cardiovascular disease and premature death, a high sodium intake can be expected to curtail lifespan. We tested this hypothesis by analyzing the relationship between sodium intake and life expectancy, as well as survival in 181 countries worldwide. What was noteworthy here is that there was an inverse relationship between sodium intake, all-cause mortality, and life expectancy. So within these developing and developed countries, increased sodium intake was actually associated with decreased all-cause mortality and was associated with increased total lifespan. Our observation of sodium intake correlating positively with life expectancy and inversely with all-cause mortality worldwide and in high-income countries argues against dietary sodium intake being a culprit for curtailing lifespan or a risk factor for premature death. But then they have the exculpatory clause. These data are observational and should not be used as a base for nutritional interventions. It's funny because a lot of other observational data is used for the basis of nutritional interventions, but I think that all of that is important, but within the broader context, particularly with kind of within an ancestral health context, we get so myopic on this stuff. So we start talking about only sodium and its relationship to hypertension and possibly cardiovascular disease. And we forget that sodium is a vital nutrient, but one of many vital nutrients. And what we also see when we start taking a broader, more holistic view of this whole story is that sodium is important, but potassium and magnesium are as well. And this paper, higher intakes of potassium and magnesium, but not lower sodium, reduce cardiovascular risk in the Framingham offspring study. And from that paper, it's possible that the lack of a beneficial effect of lower sodium intake on cardiovascular risk in this and other studies may be due to the other adverse effects associated with reducing dietary sodium intake. Some randomized clinical trials targeting dietary sodium reduction have shown unintended results, that is, increases in renin, aldosterone, catecholamines, total cholesterol, etc. So much of that story is mitigated by consuming adequate potassium and magnesium in addition to appropriate amounts of sodium. And this is where, let's see here. Yeah, here we go. Our data provide no evidence for sodium reduction in a healthy population as a means of reducing risk of cardiovascular disease in a population with moderate sodium intake. It does, however, support the importance of increasing potassium and magnesium for the purpose of reducing cardiovascular risk. Interventions focused on the promotion of potassium and magnesium-rich foods in the diet may be effective targets for reducing the occurrence of cardiovascular disease. To improve generalizability and expand these findings, future studies should examine broader ranges of intakes and more ethnically diverse cohorts. But it's interesting, there was no statistically significant reductions in risk of cardiovascular disease with lower sodium intake alone. What was critical is that folks needed the increased levels of potassium and magnesium, and then we started seeing overall benefits across the board with regards to cardiovascular disease. And this kind of brings us into some of these other considerations above and beyond just sodium intake, effects on blood pressure, and then the potential extenuating circumstances there to cardiovascular disease. So where do folks in the modern world get the bulk of their sodium from? And it's mainly processed foods. And these processed foods are almost by definition largely devoid of potassium and magnesium and a host of other nutrients. It's kind of remarkable when you see a breakdown like this. The bulk of the sodium that people get is from already processed and or restaurant foods. And, the added at the table, the salt shaker is almost a laughable contribution to this whole story. And that's maybe worth mentioning here in just a minute also. The sodium or the potassium and magnesium rich foods are the things that largely get jettisoned clearly with a whole minimally processed with a highly processed diet. I'm getting ahead of myself here. This is another one of the spots where I do think the good old paleo type diet that Lauren Cordain advocated for was so prescient, profound, like it had a lot going for it. The amount of magnesium and potassium is absolutely prodigious in a standard paleo type diet, consumed with modern foods, lean meats, fruits, vegetables, roots, shoots, tubers. We end up getting a remarkable amount of potassium and magnesium eating this way. And what's interesting then is that not only is sodium intake not injurious under that circumstance, it seems to be really beneficial, particularly for certain populations like athletes or folks eating at the lower carb side of things. So within that low carb eating, how much sodium, potassium, magnesium should an individual get? It's worth mentioning that if someone is placed on a medically supervised ketogenic diet, the dietitian and physicians will make sure that that individual gets at least 3 to 5 grams of sodium per day, and more depending on activity level, size of the individual and whatnot, usually a similar amount of potassium, and then the magnesium, up to a gram of magnesium per day, although that will vary based off of how folks respond to that from a gastrointestinal level. Athletic needs really vary markedly with regards to sodium intake. When an individual sweats, we lose almost exclusively sodium in our sweat. We lose almost no potassium, very, very little magnesium, and that is an important thing to keep in mind, because that is kind of where we want to look for improving our workout recovery and whatnot. And this is also a place is kind of outside the scope of what this talk was oriented towards, but every year a good number of people end up dying from drinking under athletic conditions, high heat, high humidity, lots of fluid turnover. They consume water without adequate electrolytes, and they end up in a sodium deficient state, and that hyponatremia can kill them. So this is what I've got for you today. We looked at a little bit of the historical underpinnings of sodium, both from, just kind of a gee whiz perspective, but also thinking about how long has sodium been a nutrient of interest with regards to cardiovascular disease and hypertension? What does the data really look like with regards to the demonization of sodium? Clearly, sodium is a player in the effect of hypertension. It is clearly a piece of that, but is it the primary driver of hypertension, or is it more of a secondary feature due to the effects of not just sodium retention, but all the other effects that we see with regards to metabolic syndrome on the potential damage to the vascular endothelium from a variety of different mechanisms. And then we definitely see some interesting mitigating opportunities with both fasting and low carb diets. Like if an individual is suffering from hypertension, a sodium restricted diet is probably not gonna help. Consuming way more sodium isn't going to probably help that individual either. But what we've seen is sodium restrictive diets with the bulk of these folks are just not really that effective. But reducing glycemic load, reducing total caloric load, improving metabolic health, that seems to improve the downstream effects of sodium pretty dramatically. And it also points out that low-carb individuals and those who are fasting probably need more sodium than what they would normally get. And the bulk of the food they eat should be minimally processed so that they get adequate potassium and magnesium. And that's what I've got for you. So take care, stay salty, and hope to see y'all in real life sometime soon.